Well, good afternoon, folks, and thank you for being here. My name is Alan Cockle, and I'm the Senior Director of Health Programs here at the Pew Charitable Trusts. For those of you who don't know the organization, Pew is a nonprofit, nonpartisan research and policy organization, and our work touches many pressing policy issues across American life and internationally. But for the purposes of today's conversation, this event is hosted by our Drug Spending Initiative, which is a research initiative focused on the drivers of drug spending and on possible policy solutions at the federal and state level to address rising drug spending. With my colleagues, I'm delighted to have you here today and also welcome folks who are watching live on the webcast. We're looking forward to an informative and interesting discussion. As probably everyone in this room knows, drug spending is very much in the news, sometimes hourly, thanks to the president's tweets. And annual spending on drugs in the United States now exceeds $450 billion. In the next short while, next few weeks, Pew will release a new report that actually provides a new analysis of where that $450 billion goes and which pockets it comes out of and how it accrues to various entities and consumers across the supply chain and across different plans and parts of the coverage landscape. But drug spending is projected to continue growing and growing faster than the cost of medical inflation. This is certainly something that the public has noticed. The Kaiser Family Foundation tracking poll tells us that 4 out of 5 Americans say the cost of prescription drugs is unreasonable. And what's more, over 80% of people surveyed say that Republicans and Democrats in Congress are not doing enough to keep costs down, and 77% say the same of President Trump and the administration. So we will hear today from 2 top HHS officials about the administration's drug pricing blueprint, which has the potential to affect Medicare and Medicaid, other public programs, and the commercial market. For scheduling reasons, the way the day will run is we will have our first state panel, we'll have our federal speakers, and then we'll have our second state panel. And of course, rising drug costs do have huge implications for states. States encounter drug costs both as payers and as regulators. Medicaid programs are the second largest line item in state budgets. Drug spending in Medicaid amounts to over $30 billion a year. But states also pay for prescription drugs for public employees and retirees, and for people in prisons. So as we will hear today, a number of states have enacted measures aimed at different parts of the drug spending landscape. Many states are looking at how their Medicaid programs pay for drugs, and they're testing new models. One example that we won't talk much about today, but New York State has implemented a cap on Medicaid expenditures for prescription drugs with a mechanism to identify specific drugs and obtain additional rebates. That system is now being implemented and tested for the first time. Other states are looking at the role of pharmacy benefits managers, PBMs, which are the entities that insurers contract with to negotiate discounts with drug manufacturers and administer the prescription drug benefit. A number of states have taken steps to increase transparency, and still others have sought to more directly regulate prices. For example, Maryland enacted a law last year that was intended to prohibit what the law called unconscionable increases in the price of essential off-patent or generic drugs. That law has since been struck down as unconstitutional, violating the Interstate Commerce Clause. And that serves as an example of one of the obstacles that states face in trying to tackle drug spending. One of the things we will hear about today is some of the tools that they may have at the disposal that won't violate that clause. So today we will hear from lawmakers and others in states who have advanced new approaches to address pharmaceutical costs, and from policy experts about other tools that states are considering or may consider in the future. Our aim is to focus the discussion on current and emerging policies and to assess their potential. I'm very grateful to today's participants, many of whom have traveled a long way to be with us. And before we dive in, I also want to thank Pew's drug spending team and especially Alyssa Chester, who've done all of the hard work to put today's meeting together. A couple of other housekeeping items. The meeting is being webcast live. There is press in attendance, and we welcome you. If you are tweeting, we have a hashtag PewRxTalk today. And if you need to step out, the restrooms are just over there by the elevators. There are refreshments just outside. Please help yourself, and you're welcome to bring them into the room. So now let me invite the first panel to come up and join me up here. And as they come up, I will just briefly begin introducing them. The first thing to notice is that we have Senator Yvonne Cancela from Nevada, Senator Ron Caldwell from Arkansas, and Kelly Coates, who's the Associate Vice President for Clinical Support Services with the University of Texas Medical Branch Clinical Support Services. Please go ahead and sit down. So the thing to notice here is we have very carefully selected panelists who all come from parts of the country where it is hotter than it is today in Washington, D.C. So let me just shift over here. Thank you all for being here. So I'm going to start to my immediate left, and I'll just have each of them just sort of give a brief overview of what they've been working on in their states. So Senator Cancela represents Nevada's 10th district, chairs the National Resources Committee, and serves on the Commerce, Labor, and Energy Committees, and was the principal sponsor of legislation in Nevada to address diabetes drugs. So welcome, and would you tell us a little more about what you've been working on?
Sure. Good afternoon, and thank you for the introduction, Alan. I represent the most Vegas-y of Vegas districts, which means I have the Strip, the University, the airport, the convention center, and I also represent the people who work in the casinos, which means that the high cost of prescription drugs really affects the folks in my district. And in Nevada, 12% of all people have diabetes, 28% of all people are pre-diabetic, and by the year 2030, our population of people with diabetes is set to double. At the same time, the cost of insulin, depending on the vial you take, has skyrocketed to anywhere between 300 and 1,000%. And as a reminder, insulin is a 95-year-old drug. I was appointed to the legislature in 2016, and I thought it was really important to look at those two figures together and recognize that what we have is a public health crisis that leaves people unable to afford the medicines they need, in most cases, to stay alive. So we passed legislation, bipartisan legislation in Nevada, that addresses the entire chain of drug pricing. We started by looking at drug manufacturers and put in a number of transparency mandates on manufacturers of essential diabetes drugs. We have similar reporting for pharmacy benefit managers, and went all the way down to pharmaceutical sales reps and put in much of the language that's in the Affordable Care Act, but also went farther and said, we want to know what kind of samples are being left behind. And the legislation took all sorts of different twists and turns, but ended up being something that we're really proud of in Nevada, and we're looking forward to seeing the first set of data coming out in January of next year.
Thank you. To your left is Senator Caldwell, who represents Arkansas's 23rd district and is vice chair of the Hospital and Medicaid Study Committee, as well as vice chair of the Senate Rules Committee. And he has been a leader in developing Arkansas legislation to regulate pharmacy benefits managers, legislation that's now in the process of being implemented. Thank you for being here, and would you tell us a little more about that?
Thank you. Glad to be here. Most people don't realize that when you go to your local pharmacy and receive a prescription, that local druggist does not set the price on that prescription. That is set by a pharmacy benefit manager. And so when it comes to competition, it's very hard for someone to compete when they have no authority in setting that price. It came to light in early January of this year with a new program that was instituted in Arkansas, that many of the prescriptions that the local pharmacies were filling were being reimbursed at below their cost. And through some research, we were able to get onto a portal of one of the insurance companies and see through their explanation of benefits that some of the PBMs were reimbursing their own stores and their own companies a much higher rate than what independents were being reimbursed, to the extent that on one reimbursement, a local independent would be reimbursed $13, where CVS Caremark would reimburse their own store down the street $1,436. So extreme differences in this, and some of that information has been provided. Because of that, we were able to ask the governor to call a special session, and we passed a bill that will cause the PBMs to be licensed in Arkansas for the first time. Basically, our doctors are licensed, our pharmacists are licensed, our insurance providers are licensed, but the PBMs are not licensed or regulated. And what we want to do is to develop a way to provide transparency that will allow the public and the government to see exactly what these drug costs really are.
Thank you. And Mr. Coates, I think I mangled the university before, so let me try again.
No worries.
The University of Texas Medical Branch Correctional Managed Care Division.
Correct.
Which provides healthcare services for about 120,000 inmate lives.
Right.
And as you will hear, this is a program that has enabled Texas to keep its drug spending in its prisons far below where other states are. So would you tell us a little more about that program?
Sure. Well, thank you for having me today, Alan. I certainly appreciate the Pew organization having someone from this great state of Texas come out, along with our colleagues from Arkansas and Nevada. But I would like to say thanks. I'm the Associate Vice President of Clinical Operations and Support Services at UTMB, which is UT Medical Branch in Galveston. And what we do there is we provide health care for the state of Texas, for all the offender population there in the state of Texas. We share that load or that burden with Texas Tech, which is kind of our collaborators on this. We do about 80% of the state. Texas Tech provides services for the other 20%. We have the only prison hospital in the United States on the campus of UTMB down in Galveston. We have outpatient clinics in every one of our facilities that we service, which is about 85 facilities, from the Valley all the way up to the Arklatex border in Texarkana. We have 340B drug pricing, which has saved us a tremendous amount of dollars for the taxpayers of Texas. It's been in effect since 2002, when we were granted the ability to do that from the OPA. And it has saved tremendous amounts of money, and we feel like 340B is the way to go for any state system. Our system is unique in that it is an academic collaboration between the two universities and TDCJ, Texas Department of Criminal Justice. And so with that, that's what we do.
Thank you. So I want to spend some time on the policy implications of all of these things, but I also want to understand a little bit about the how. People in states may be considering any one of these policies and understand that anything that touches drug spending attracts the interest of some big stakeholders. So would you tell us a little bit about what they can expect, what your process was in your state, what it was like as you developed this policy and moved it forward? Senator Kinsella, we'll start with you again.
Sure. I joke that I went to put my foot in the pool and ended up kind of way in the deep end, in that I did not expect there to be the kind of opposition that there was to the legislation that I put forward. And I think there were three major takeaways for me and that are exportable. The first is that drug pricing affects constituents in every district, and that if patients aren't leading the fight, if they're not the face of the work, it becomes much easier for outside groups, lobbyists, different influence groups to say that it's not possible, we can't do this. It's only in having the real stories for how this pricing forces people to choose between keeping their lights on or being able to take the medicine they need to stay alive that really we were able to move the dialogue in a different direction. The second is that there is a lot of competing data to show why legislation like this shouldn't move forward. So PBMs have data, manufacturers have data, insurers have data. There's a lot of different numbers that say different things. And I think one of the things we learned as policymakers in Nevada is that without our own data to be able to assess the problem, we were left kind of to figure out and wade through that pool. And it's why I think the work that Pew is doing is so important, but also why the bubble of kind of lobbying and data that gets presented against this legislation makes the case itself for why transparency is necessary for policymakers. And the last thing was that the opposition grew very quickly in very unexpected ways. So in Nevada, we were focused on diabetes drugs, but we had letters coming in from groups like the Epilepsy Foundation saying that our legislation was going to destroy access to epilepsy drugs. And there was a massive campaign launched in unexpected ways to try to discredit the work that we were moving forward. And I think it's really important as policymakers to be aware that opposition will come from unexpected and far-reaching places, and having a coalition, particularly of folks who are affected by the high cost of drugs, and that ranges from patients to employers, to counter that is the only way to be effective.
Senator Caldwell, what was the experience like in Arkansas? And also the most recent legislation regulating the PBMs is not the only bill in Arkansas that the legislature has taken up in recent years in this area.
That's correct. In 2015, we took up a piece of legislation on maximum allowable cost, or MAC, pricing. That legislation was recently struck down, parts or all of it, in the 8th Circuit in St. Louis. Our Attorney General is presently weighing her thoughts on whether to appeal that to the U.S. Supreme Court. So that may not be totally defunct right now. But the other bill that we passed passed with tremendous support in both the House of Representatives and the Senate, with only 2 votes against it out of 100 in the House, and only 2 votes against it out of 35 in the Senate. So, but again, there was quite a lobbying effort from the PBMs not to have this passed. Basically, what it will do, we're in the process right now with the Arkansas Insurance Department setting rules. At final meeting, I think, will be tomorrow in Little Rock, and to try to implement this. But basically, it wants to provide transparency so that the insurance commissioner will have the authority to actually see the contracts. Obviously, he can't disclose those, but he will be able to see those to make sure that they're fair and just for all parties. One of the issues the state is so interested in is that we use state money to actually buy insurance premiums or insurance policies to pay the premiums. Unlike other states, we put in a kind of hybrid form of the Affordable Care Act, and that we actually, for a certain group of working people, we actually buy their insurance policy at this time through Blue Cross Blue Shield of Arkansas. And so the state is paying that policy, and so it's illegal for the PBM to pay a different rate to their own company stores than it is to an independent. And that's one reason that we're so interested in it. Are we paying the money that the PBMs charge for these drugs come from one place, and that is the premium of the insurance policy. So our contention is that our insurance premiums are excessively high because the price of drugs are excessively high.
So the PBMs opposed this?
The
independent pharmacies supported it?
In fact, we had to have the fire marshal to come and clear the room. It was the largest turnout for a committee meeting ever in Arkansas.
Now, and what role did the chain pharmacies and the plans themselves play?
Some of the chain pharmacies are in favor of it because not all of them have the same reimbursement rate as the allied companies of the PBMs. Express Script obviously has their PBM function, but they also have their mail order pharmacy. CVS and others are the same. CVS Caremark has their PBM function, but then they have their retail stores and their mail order prescription. They were opposed to it, but then you get back into other chain stores such as Kroger, who has many pharmacies, was in favor of the bill because they want a fair reimbursement just like most people do.
Thank you. And I should note, we did reach out to CVS Caremark for a comment on this differential reimbursement, and they provided a sort of general comment about the role that PBMs play, but they didn't comment specifically on the alleged or reported differential
One other
reimbursement.
thing that happened during this time frame is that CVS sent letters to many of the independent drugstores telling them they know that times are tough and business is hard. If you're interested in buying or interested in selling your store, we're interested in buying that store. So, very anti-competitive.
Kelly, the system for delivering health care in corrections in Texas is older than these other things we're talking about. But would you tell us a little bit more broadly about how that works, and then at what point did you establish the system that you use now for providing drugs using the 340B acquisition process?
So Texas actually, kind of this new system, academic model that we use, actually came into existence around 1993. It was out of two landmark cases, Estelle and the Ruiz case, that affected Texas. And so there was a mandate that came down for a correctional managed healthcare committee to establish the healthcare for the offender population in Texas. And they did that by separating out into, and one of their mandates was to use the academic institutions, medical schools in the state of Texas to provide that health care. And so they chose University of Texas Medical Branch and Texas Tech. So it's evolved over time. It was under federal oversight for a number of years, finally came out of that in the early 2000 time frame. And then, again, like I mentioned earlier, in 2002 is when we really ramped up the 340B pricing and were able to get that approved. It is for an underserved population. We have a number of innovations in the state of Texas that, quite frankly, are just now coming into the foreground of healthcare in the free world. One is telehealth. We're the second largest provider of telehealth services outside of the military in the United States. We have one of the largest dialysis operations in the United States. And again, this has evolved over 25 years. We have a centralized pharmacy in Huntsville that distributes all of the medications across the state through a very complex transportation system that we have. So we've really kind of honed in and, again, evolved this over time. Many states go back and forth between their Department of Corrections or a private vendor delivering health care. This is a great model because it is true managed care. We can be a little more conservative when we need to. We have a very robust utilization management and review process. And then, of course, we have our specialists down on campus, down at UTMB, providing the specialty health care. And then when we do, you know, as everyone knows, we want to minimize the amount of time that offenders are on the road. So our telehealth operation has just expanded and blown up in the last 10 years. So we're able to use specialists down at Hospital Galveston who are actually providing that care out to units without them having to travel. So that's kind of the whole genesis of where it began.
Now, Pew recently released a 50-state report on, or a series of 50-state reports on how different states deliver healthcare services in their corrections system. Maria Schiff, who is here, led that work, and if I recall correctly, only a fairly small share of the states that responded were actually able to break out their drug spending from their other healthcare spending. But of those, Texas was half or less the share of drug spending compared to other states. Why do you think that is?
Well, again, the 340B drug benefit, I think we've saved approximately $650 million over the 15 years of the life of this program. Last couple of years have been really robust only because the cost of drugs have gone up so significantly. So I want to say last year was around $90 million that we saved in 1 year alone. So I think that, along with we have a high rate of generic use within this managed care program. We have what we call disease management guidelines that are created by our physicians as well as our pharmacists. And we have a number of physician extenders that are able to see patients as well. So our total health care for an offender in the state of Texas runs about $13 per member per day, which puts us about number 45 of the 50 states as far as cost to provide the health care. But it's quality health care. I don't want to give anyone the impression that, you know, we're trying to be the cheapest. We try to provide value to the taxpayer of the state of Texas.
You remember off the top of your head what the drug spending was as a share of total health spending?
I don't. I believe it's 7%.
That's the number I had.
Correct.
In my head. Yeah. Senator Caldwell, in Arkansas, you're now in the process, as you said, of rulemaking and implementing this legislation. Big picture, what's your hope for what it will achieve?
Well, one thing we want to do is reduce the drug cost, not just to the individuals. This bill will affect every household in the state. Every household in the state takes medication. Theoretically, it will reduce their prescription drug costs. It will reduce their insurance, health insurance premiums through reduced drug costs. We are working to make sure that availability of health care is not affected. Arkansas is a very rural state, much like Nevada, and yet you go into the cities where you have many people, and it's the urban areas that will find lacking in healthcare availability. In Arkansas, the retail pharmacist is probably ground zero for healthcare. That's their first line of defense as far as taking blood pressures or taking over-the-counter medications. And most towns will have a pharmacy, but most towns may not have a doctor. So we're looking to try to keep the retail pharmacy open just as a line of defense for providing health care. There again, we hope that this will reduce both the cost of medication and the cost of health care premium.
And if you would, say a little more about how that might work. So PBMs will have to pay a bond and, as you said, submit their contracts for review. What is your hope that the Attorney General, the Insurance Commissioner, will be able to do with that information? Well,
if they have to be licensed, today they're not licensed. Anyone can come in as a PBM and do business in Arkansas. Now they're going to have to have that license, be required to have the license, and if we find through the insurance department or the Attorney General that they are not providing the services and the coverage and the medications on a competitive basis, then they can come back before the Insurance Commission for review, and the Insurance Commissioner can fine or actually pull their license not to do business in the state.
In the channeling what the PBMs might say is you're tying our hands here. We had established a preferred pharmacy network that we used to deliver good value to the plans, and you're taking away the tools that we use to deliver value.
I don't think we're taking away any tools at all. The real issue is there's no transparency, and to come in and to have a company establish what their competitor can sell a product for, no matter what that competitor paid for that product, and the fact that we have documentation of over 250 drugs that the PBMs are paying themselves more than twice what the independents are being paid, establishes our foundation for the need of some type of control. If we could reduce drug spending by 50%, obviously it would be lots of dollars saved. The issue is that we're not trying to put anyone out of business. By the same token, we don't want the PBMs to put anyone out of business either. We want to have the availability and accessibility of health care throughout the state, and that includes rural and urban areas. And we had many retail pharmacists from rural and urban pharmacies to come in and tell how that the fact of the pricing system that's established today, that they're being paid below their cost on medication, is the fact that, and that cost is established only by the PBM. And there's no true appeals process. We can appeal some, but when you go back and look at the appeals process, a very minor percentage of the appeals are ever changed. And when you look at the total dollars brought back into the stores through the appeals process and the time and effort that they have spent doing that, it's actually a negative cash flow. So we just want the accessibility of health care. But again, with Arkansas and our unique program that we cover some of the people on the Affordable Care Act, is that state dollars are spent on those insurance policies. And the prescription prices, the prescription dollars come directly through those premiums. And if we can reduce the prescription prices to a sustainable level, then our savings to the state should come through the reduction of healthcare premiums.
Is there any risk that rather than lowering their payments to their own pharmacies, they raise them to everyone else?
I guess you would have that risk. Again, that comes back under the auspices of the insurance department.
Right. Well, on the subject of transparency, let's bring it back to Nevada. Big picture, what do you hope that the Nevada legislation will accomplish?
Well, I want to backtrack for a second and just say what I wanted it to accomplish and kind of where I think the research and discussion needs to go. The original intent of the legislation was to figure out a way so that when the cost of essential diabetes drugs exceeded medical CPI, patients and insurers would be able to apply for a rebate directly from the manufacturers. It would be done through the Department of Health, and we had figured out with the department how that would work and had started really figuring out what would have put money back in the hands of consumers and insurers in a way to deter price gouging. Unfortunately, we ran up against the Commerce Clause, and I'm hopeful that folks in this room who are thinking about these issues, and certainly folks who are much smarter than I am, will figure out how to get across that finish line so that patients and states can actually work together to get money into the hands of consumers and truly deal with the price gouging that happens. So that was what I wanted to accomplish. But what we ended up with, and what I think will be tremendously meaningful, is a piece of legislation that will insert transparency at all parts of the pricing system. So one of the things that comes up anytime you talk about the relationship between drug manufacturers and PBMs are the rebates that get negotiated between the two entities and ultimately then dealt with insurers in terms of where drugs get placed on formularies. So part of the legislation creates transparency around rebates, not only from manufacturers to PBMs, but from PBMs to insurers, in the hope of letting patients see where they are missing out on the affordability that gets inserted throughout the drug pricing chain. I believe that manufacturers start the entirety of the discussion in that they set the first price. And there are lots of different acronyms and prices. There's list prices, there's WAC. What we want to understand is what number ultimately is the difference between what a consumer pays and what a drug manufacturer sets the cost at. And I think that information is important, not only for the state to then be able to make policy based on that difference, but for patients to be able to answer the question, why is my medicine so expensive? How is it that my medicine that I need to stay alive has gone from $300 to $3,000 with no explanation? And I'm hopeful that creating transparency across the spectrum will equip patients and policymakers to answer that question.
And what I wondered the first time I heard about this legislation, and I know you get asked it all the time, is you talked about the prevalence of diabetes in Nevada, but why just diabetes drugs? Why not do everything?
Well, that was both, it was a strategic decision in looking at what had happened across the country with what legislators had attempted and what they'd actually been able to get done. And it's very clear when you look at the landscape of how many bills have been proposed and how many have actually become law. I think it's about 600 bills have been introduced related to drug pricing, and only about 50 have actually become law, that there is a lot of interest in protecting the status quo around drug pricing, and that states have to be creative in figuring out how to get stuff done. And in talking to employers and patients and insurers, the cost of diabetes across the board, both in the public and private sector, is either the number one or the number two driver of drug costs across the board. So it seemed like an area that both could make a difference and that there would be support around creating transparency in.
And you talked about the differential in what a patient pays out of pocket and what the sort of true price is. If the patient's copay or coinsurance could be managed in a way that was acceptable to the patient, in a fair way, for lack of a better term, would that achieve most of what you want to achieve, or are you also trying to tackle the sort of total costs?
So I don't think it has to be an either-or choice. I think we can both manage copays and deal with the cost of drugs themselves. And I think when we just focus on one part of the spectrum, we ignore that manufacturers play a tremendous role in how insurers ultimately set copays. And I think it speaks to what Senator was talking about, and that the cost of insurance goes up as the cost of drugs goes up. And so it is a Band-Aid solution, in my opinion, to just look at copays, and it is important and certainly makes a difference in the lives of patients, but it does not address the overall challenges we face in that the cost of drugs go up and every other entity in the drug pricing system reacts to that.
So I can keep asking questions, and I will, but I also want to go to the audience. If anyone here has questions, we have some microphones, so I see Jane over there. But while we're getting organized for that, let me ask you a variation on the question that I asked Senator Caldwell, which is, you know, a response to this transparency may be that confidentiality in pricing and confidentiality in rebates is a commercial advantage that allows various purchasers to get good deals, and that if all the cards are on the table, so to speak, that enables price fixing. Are you concerned about that, and how do you respond to that?
So drug pricing legislation isn't just about drug pricing. It ends up being all about trade secret law and these kind of different practices that take place, something that I have learned more about than I ever thought I would. And what was at the heart of the lawsuit that came forward as a result of this legislation. I don't believe that anti-competitiveness is a result of transparency. I believe that it levels the playing field so that patients and policymakers have unbiased data to make decisions off of. And I think that there are ways to legislate and protect any sort of hyper-confidential information that could end up truly affecting business practices. And we in Nevada tried very hard to be thoughtful about that and put those protections into place. And the regulations that have been implemented were all about figuring out how to create a process by which to protect that data. And in some states, so in Vermont, for example, the trade secret language that's in their statute prevented any real data from coming out, even after they'd passed some pretty comprehensive transparency legislation. I'm hopeful that the same won't happen in Nevada and that we'll be able to see real data. But it's difficult to know whether or not it will affect business practices if we don't at least attempt to put transparency legislation into place. I think it's worth the risk if we're able to get the data we need to, in the end, make change.
Thank you. Jane, and if you would, anyone asking a question, if you would just introduce yourself and give your affiliation as well, please.
Sure, my name is Jane.
Oh, do we have a microphone? Sorry, one second.
I do.
No question.
Hi, my name is Jane Horvath, and I work with states on drug pricing policies. And Senator Cancela, I was wondering if you could talk a little bit about the patient group reporting in your legislation. I think it's really, really important.
Yeah, one of the things that has happened across the country and that there's been some pretty extensive reporting on is that what should be patient advocacy groups end up being almost entirely funded or increasingly funded by different players in the drug pricing scheme, particularly drug manufacturers, and that it does lead to potentially biased dissemination of information. And it's not to in any way say that these groups don't do good work. That is not at all what I'm saying. But it is important, if we're relying on groups to be patient advocate groups, to know that they are in fact advocating on behalf of patients and not functioning as an extension of drug manufacturers or insurance or PBMs. So one of the provisions that we put into the legislation is that all healthcare nonprofits that are operating in the state of Nevada have to report to the Department of Health the donations that they're getting on an annual basis from drug manufacturers, PBMs, and insurers, so that we can know who we're talking to at the other side of the table in a really transparent way.
Thank you.
Could I add one thing while
Please
we're
do.
talking on this, talking about pricing from the drug manufacturers? Most of the drug pricing issue is not on patented drugs, name brand drugs, it's on generics. One issue of coming through, talking about transparency and drug manufacturers, on the drug Harvoni, which is used for hepatitis C, today it sells for about $31,000 or cost about $31,000 per dose. The PBMs will pay themselves about $700 profit. Yet if you fill that same prescription through an independent store, the PBM will only reimburse that independent store about $11,000 and keep about $20,000 in profit. So this is a transparency that we're talking about exposing on what's going on. And so this price is coming through from the manufacturer at $31,000, and yet you get to rural locations, and if you don't have a name brand, in this case CVS store, that pharmacist cannot fill that drug because he's going to lose $20,000 a month on it.
Well, you bring up Harvoni. I think a lot of people would look at drug spending and see the share of drug spending that's generic versus the share that's brand, and actually see the opposite trend where the generic spending, there are certainly products that have gone up, but as a whole, that category continues to hold down pricing. But I want to go to Kelly, because the Hep C drugs, which are still on patent, beforehand we were talking about the difference that you're finding between the Hep C environment and another category that's important in the correctional system, which is HIV drugs. Right. Could you say a little bit there about how the market dynamics are playing out?
Right. So as many know, I mean, there's been a lot of competition in the Hep C arena for the new direct-acting agents. We've seen the prices come down fairly dramatically over the last 3 to 4 years. And so, but it still causes a huge strain on state budgets, because you do have a larger prevalence of Hep C in the state incarcerated population in the states. So we are trying to, it's a very measured approach on how we treat hepatitis C. We've got a very methodical system of choosing who is going to be getting or prioritizing, I guess, treatment. The HIV population has stayed basically the same within the state of Texas for the last 15 years. It's roughly 1% of the population, but it takes 40% of our drug budget. So it's a fairly significant amount of our drug budget is spent on HIV drugs.
Thank you. Jim Scott.
I was going to ask about hepatitis C.
Right. Any other questions? So one thing, just sort of following up on that I wanted to ask you, I think you might have alluded to this earlier, but what is your assessment of what happens when people leave the correction system in terms of these kind of chronic maintenance therapies?
Sure. And that's a tough one because, I mean, a lot of communities don't have discharge planning or continuity of care out in the free world, is what we call it, outside of the walls of the prisons. We are working very hard. We have a grant actually down in Texas for, it's a Minority AIDS Initiative grant, where we actually do discharge planning with AIDS service organizations in the Texas area that actually draw in the offenders once they've come out for HIV. We're working on a similar program for Hep C with one of the pharmaceutical companies as a continuity of care. So, you know, the patients who are discharged out of the system can then be drawn into their side as far as care goes. Because we know, I mean, even though they may not get treatment in the prison system, their disease state is going to advance, right? You're going to get to chronic liver disease at some point in time, and so they will need to be treated. And so identifying those individuals on the inside so they can be taken care of on the outside is kind of the next step in our process.
And while we're on that subject, do you want to talk about cancer drugs and some of the other treatments for diseases that we really associate with an aging population?
Right. I mean, that's one of the big challenges we have in the offender population is the over 55-year-old population, and I'm 55, right? So I can say that it doesn't feel like it's old, okay? But in the incarcerated population, we predict that offenders who are 55 and older typically are experiencing the same level of chronic health conditions as someone 10 to 15 years older. So the acuity, the chronicity is much greater in that population. So what happens is, again, they're taking a lot of our drug resources. Cancer therapies in particular have become almost a chronic state, a chronic disease, because you can maintain folks on cancer therapies for longer periods of time than we were ever able to in the past, just like HIV drugs, just like hepatitis C drugs. So,
question here.
Hi, Joyce Frieden from MedPage Today. I wondered if either of the senators can talk about the involvement of the physician community in either of your initiatives, and I'm interested in, like, are the doctors aware of the problems Senator Caldwell, you mentioned about filling the, Harvoni prescription in the rural pharmacy? Are they sending patients elsewhere, or, what has happened?
In the Senate, we have the wife of a physician, and in the House, we do have a physician in the House. Yet I've never seen any testimony from the medical society on this. And normally, when the physician writes a prescription, the only feedback that he would get would be from a patient that might go back and discuss the use of another drug if it's not available or unaffordable.
We had a few physicians themselves, and I'm trying to remember if the association testified neutral or not at all, but there was a small concern around whether or not samples would stop coming into the state and stop coming into doctors' offices if manufacturers were asked to report that. It did not percolate to a big enough issue to where we had to take out that provision or really address it, but that was the discussion we heard from doctors themselves.
And while we're on that, you talked initially about the importance of the patient voice. Was that organic, or was somebody organizing the patients? And in what way did you hear from patients?
I'm so glad you asked about that, Alan. In a number of different ways, patient voices were heard as part of this legislation. So in Nevada, the Nevada Diabetes Political Action Coalition got established, and it's not a PAC, it's just a coalition of folks who have diabetes and live all over the state. And they came up to Carson City, which is Nevada's capital, not Las Vegas, and testified to what it was like to experience having to choose what to do in your family when the cost of your insulin goes up from $200 to $450, and what that means for a person's life. We did a press conference, and there was one mother who told the story of being afraid that her 11-year-old son was going to find her cold body because she had been off of her diabetes medication for almost 3.5 months at that point because she couldn't afford it. And it was these really intense stories that started as an organized effort to identify patients and grew out so much that we had folks from all over the world testifying through Twitter and Facebook and sending comments to legislators on what their experience with diabetes was like. And it's really a testament to the Insulin for All movement, which if you're on Twitter is the hashtag Insulin #4all, that we were able to hear from so many different patients. And I know there's some folks here in the room today who I've gotten to know and who have been brave enough to share those stories. And I think what we're seeing across the country is an increase in patient advocacy in both an organic and organized fashion of folks saying enough is enough, we really do need to take action. So I personally, I think it's the most important part of how we get this legislation passed at the state or federal level.
Thank you. We have an audience question here.
Ji Bai from Johns Hopkins Carey Business School. I have a question to Senator Caldwell. So in Arkansas, how does the state determine the fair and reasonable price that PBM should reimburse to pharmacy? So obviously, the internal transfer pricing between the PBM and their own pharmacy is not supposed to be a fair and reasonable because it's an internal transfer pricing, right? So I'm curious if you can spend time on this.
I don't know that I totally understand the question, but the difference in the pricing, and I don't know if you have that list available that I sent in, you may, but there's a significant difference in pricing. One example came to light during testimony was on Tamiflu. It's where a mother with 2 children went into the rural pharmacy with prescriptions for Tamiflu. The Tamiflu cost a pharmacist about $86. The children prescription reimbursed the pharmacist $96, so she made a $10 profit. The mother was going to fill hers. Now, the 2 children were on regular Medicaid, and the mother was on the hybrid Medicaid where we actually buy an insurance policy with state funds. And the Tamiflu, again, cost $86, and the pharmacist was going to be reimbursed $36 on the mother, all at the same time. So they go into the explanation of benefits portal and look, and CVS was charging Blue Cross Blue Shield $129. So CVS was getting paid $129 for the prescription, only reimbursing the pharmacist $36. So she was going to lose $50 on that prescription, while CVS was going to make $90 on that prescription. And that's one of the problems we have. We have a whole list of medications, about 250 different medicines that we were able to pull off that explanation of benefits portal, and shows a significant difference. More than twice the price was paid to a company store, CVS store, than it was to a local independent pharmacy. We have that information for you.
I actually would love to go back to the questioner just for a moment. I think if I heard you correctly, the part of your question posited that the price that a PBM pays its own pharmacy, you called it an internal transfer price, is not supposed to be, you didn't use the word market price, but would you say a little bit more about what you meant?
I'm an accounting professor, and one of the topics we talk about is internal transfer pricing. And let's say General Motors dealing with a supplier in South America, and the price between General Motors in the U.S. and the price and the buying price from the supplier in South America is considered internal pricing, and the company has every single right to determine the price for the purpose of maximizing the tax benefit. So that price is not determined by market force alone. It's determined by many considerations. So then in this case, PBM can say, you know, we decide this internal transfer pricing for whatever reasons. So you cannot use this to determine a market price that can be used for other independent pharmacies, right? So I was thinking, you know, in the court, court cases, this can be a problem, right? So the state, I think, has to somehow specify what's the mechanism to determine this just, is fair, and reasonable price.
So thank you for clarifying that. I don't know that we'll fully get to the bottom of that now, but from a process point of view, if we accept for a moment that the price the PBM pays its own pharmacy is not ultimately the price that is going to prevail as the insurance commissioner looks out at what's a fair price to the independent pharmacies, what's the process that's being established in Arkansas now for the insurance commissioner to look at those prices?
That's what we're doing tomorrow. That is a process in process. I mean, we are working on that right now to establish those rules and try to get to that point that could be a fair and just process for all involved. Again, we're not trying to put the PBMs out of business. In 1970, early 1980s, 90% of all prescriptions were self-pay. And so the PBMs have evolved, much like Visa and MasterCard has evolved. When you go to the pump to buy gas, you stick your card in, the pump electronically says that this card is good to let you buy gas, and you buy $50 worth of gas, you owe Visa $50. Visa will return $48 or whatever it is to the retailer. And at that point, and that's the way the PBMs began in years past as a transaction company. And now, instead of having just a standard transactional fee, they've come out and seen all these hundreds of billions of dollars out there that's being transferred, and now they're taking parts of that. So when you stick your card in the pump, you expect to pay $50. The retailer has a prearranged price on what he's going to be paid for that transaction. But with the PBMs, that's a totally unknown. Beginning January 1st of this year, these prices changed without notification to the retailers, without notification to the providers. And the PBMs just pay them whatever they want to without any negotiated fee or price or predetermined reimbursement. And that's what has caused our state to act in the manner that we are, because our retail pharmacists, chains and independents alike, are being put out of business.
Thank you. We had a question here in the middle.
Thanks, Ellen. Mike Miller, I'm a physician policy wonk for about 30 years now. This may be a little bit too of a technical question, but back, at least since the late 90s, the pharmacists used to get compensated based upon a reimbursement, a fee for dispensing the medicine, dispensing fee. That was the term. So they'd get like $10 for dispensing the medicine pills. Mm-hmm. That's clearly changed to now they're getting a percentage, or they pay so much for it and they get reimbursed differential amounts, what you're talking about. And it was different than just the percentage they paid to a credit card company, or the loss they took to a credit card, which is a percentage of the total. It was actually a fixed dollar amount. Mm-hmm. Can you guys talk about the and then the rebates were between the payer and the pharmaceutical company. So that's where that transaction and those savings would occur, or whatever. Can you guys talk about, if you know, how that flat dispensing fee went away, and the dispensing pharmacists sort of now got caught up in the middle of this, pricing negotiations and compensation schemes? If you guys don't know, that's fine. I'll query somebody down the road.
I'm an Ace Hardware and lumberman.
One of my best friends growing up was an Ace Hardware guy. Still is. 4 stores.
I'll tell you what. Why don't we take that question? We'll table it, because I think our next panel will be able to speak to that. I have a question from Mark, and go ahead. Just hang on one sec.
Mark Miller, Arnold Foundation. So just 2 questions, if you could care to comment on these. Senator Kinsella, when you were making the point about information, the asymmetry in information, and you said your patient stories really help move things forward, I'd be curious about what you felt the strongest arguments were from the manufacturers and the PBMs in trying to counter that, and particularly in the manufacturer's case, given how long insulin had been off patent, what their arguments were. I'm just sort of curious what they would said back to you. And then to Kelly, one point that you made was that 340B was kind of a big factor in how you're containing your costs. And you may have said this, and I may have missed it, so I apologize. But did you move the prison population to 340B, outpatient settings, or did you move the outpatient settings to the prisons? And if you said it, I apologize if I missed it. I'm just sort of curious how you executed it. Just a few more sentences. Sure.
Go ahead, Kelly.
Well, I mean, the existing outpatient facilities have been in place for many, many years. So we moved 340B to those facilities. We didn't do it the other way around. So that was kind of the crux of how we did it.
And
yes, sir.
It's a great question, and maybe to say another sentence or two on that, because there are other states that access 340B to some extent for their incarcerated population, but not the way you do, which is locating a university-owned facility in every prison. Would you talk a little bit about that was not an overnight process. Would you talk about the investment required?
Correct. Well, the prisons themselves were built with outpatient clinics in mind. Even the older prisons had them. How they were manned, how they were staffed, before 1993 was totally different. Employees were employees of the Texas Department of Criminal Justice, and as colleagues of mine in other states who use DOC employees can attest, that's not always the best setup. Going to UTMB and having UTMB come in, because it's a medical branch, because it's got licensed individuals who are actually providing the care there, it kind of shifted the level of professionalism and the level of expertise a little bit to the right as far as the experience curve goes. So, I mean, and that was, again, mandated in law that we had to do that because of those two cases I mentioned earlier. But you're right. I mean, there are many hybrid situations in a bunch of different states. Ours is the only state where we have 80% of the state who does it that way. Again, my Texas Tech colleagues do not have 340B. It is because we are disproportionate share down at UTMB in Galveston, and that allows us to provide this drug benefit to our incarcerated population.
Okay. And then the question about...
Right.
Should we restate the question? The question was... what was, as I recall, what was the sort of strongest argument you heard from the PBMs and the manufacturers related to this legislation?
So the PBMs were not engaged in the discussions around the legislation, and originally PBMs were not part of what was Senate Bill 265, which was my original bill. That bill was vetoed. The governor's message said we want more on PBMs, and so Senate Bill 265 merged with what ended up being Senate Bill 539, which is where all of the PBM pieces came in. That happened, if any of you all have participated in a legislative session in the last 48 hours, which is kind of madness of putting things together. So the PBMs were largely silent on the legislation, but were certainly concerned about Senate Bill 539 when it originally came out. The drug manufacturers, and I think this is where choosing to focus on diabetes drugs was the right decision. It was very hard to deny the outpouring of data that showed that insulin prices were skyrocketing and that there wasn't a good explanation for why. So their arguments relied on the same arguments that we hear often from manufacturers, with the most prevalent being that research and development is really expensive and that's why drug costs go up. And that may be true for a lot of drugs. It was hard to believe that that was true for a 95-year-old drug that hadn't really made a big change in the last 30 years. And there wasn't a good response to that from the manufacturers. And there was, it may still be in place, there's a lawsuit against the 3 insulin manufacturers in Massachusetts for, it's a RICO suit under essentially price gouging. And there was concern from the manufacturers that they shouldn't say too much because it could be used against them in the lawsuit. So their arguments were not particularly nuanced, or they didn't dive very deep into the whys of how insulin costs had gone up so much.
Go ahead, please.
Let me add to that, because my wife is a hospital pharmacist. It has nothing to do with my bills, not affected at all, but on the insulin prices, she has had trouble getting IV solutions, potassium chloride. solutions, which is salt water. Granted, it's sterile salt water, but why in the world, with our technical advances and abilities in America, are we having trouble providing salt water? And she can't get it at the contract price, but if she'd buy it from a different supplier at 3 times the money, she can get all she wants. So much of this is intent, and it's not necessarily shortage of supplies or medication.
Thank you. Can I just follow up on the previous question? Sure. The amount and nature of information that the state is requesting under this bill is pretty expansive, including the cost of producing the drug and administrative costs and money spent on marketing and profit and patient assistance and so on and so on. That's a lot of data and a lot of factors. How do you hope or expect the state will be able to act on that? What use will they make of that information? What's the picture they'll build and the decision they'll be able to make?
Well, what will in practice happen is there will be a report published by the Department of Health aggregating all of this data, showing trends in what's happened with the different factors over the course of time. So certainly report number 1 will be a first stroke on a blank canvas. And over time, we'll be able to have data that shows here's an increase in marketing and a double increase in price, as an example. I don't know that that's actually what will happen. But we'll actually be able to look at factors related to pricing and hopefully make decisions based off of that. And I say decisions as laws and future policy. I think it is a guiding tool, and it is a first step in where there should be hundreds of steps to actually lower the price of drugs.
So you see this as establishing a baseline for further policy making?
Certainly, yes.
Great. Do we have other questions? We have Maria has a question.
Thanks. I'm Maria Schiff. I'm with Pew Charitable Trust also, but in a different department. And I have a question for Senator Caldwell. Do you foresee, or have you already heard, any appetite within your state to use this model of the differential reimbursement for other kinds of services? For example, what I was thinking of is whether the rural hospitals have used that model to complain that they might be receiving a lower reimbursement from Blue Cross Blue Shield of Arkansas for, let's say, a normal vaginal delivery compared to what, a teaching hospital in Little Rock might get. Because this, you're talking about a particularly egregious situation of a less than arm's length relationship between CVS and, the PBM and the retail, but this differential health reimbursement has really been the bane of small community hospitals for a very long time, and has the effect of driving some of them out of business, while the teaching hospitals or the more crucial hospitals in a network can command a price for what is acknowledged to be a very similar procedure. So I'm wondering if the analogy has been made among the hospitals that might be lower reimbursed in your state.
The hospitals have not been involved in this bill at all, although there are 2 different reimbursement rates for hospitals now in Arkansas. But as far as this bill and reimbursements on retail medications, the Hospital Association or local hospitals have not been involved in that at all. But I don't foresee, for instance, diabetes medication, that same drug is required routinely for a diabetic patient in rural Arkansas, just as it would be in urban Arkansas or anywhere else. And so I don't see the expectation of those prices being different. Right now we have lots of mail order through CVS Caremark and through Express Script and others. And so it's irrelevant as to whether they ship that to a urban zip code or a rural zip code. They still get paid the same, and it's still required for that patient. But I don't foresee a differential in pricing coming about from one to the other. Right now, we have that differential in place, but that's done by the PBM, not by the insurance commissioner or health
No, but
department.
even, let's say, your state Medicaid agency or your insurers pay the various hospitals in your state different amounts for the same procedure. And
That's correct.
I realize, this is just about drug pricing. It just made me wonder whether this same argument is going to have legs in among providers that are paid less than others who have more clout.
Part of the differential in the payment to the hospitals is a difference in services that those hospitals provide. Some are basically emergency rooms in rural areas and don't provide full services. Our local hospital in my hometown does not deliver babies, do not have many of the services that a full service hospital would have. They're prevented from doing that, so but then their reimbursement rate is a little bit different than a full service hospital would be.
Okay, thank you.
Let me ask you about another element of the Arkansas legislation, which is gag clauses. So if I remember correctly, about 16 states have banned gag clauses, and it's also something that is proposed in the President's blueprint that our federal speakers may address when they get here. But would you say a little bit about gag clauses and the concern that you had there?
We do. The retail pharmacies received a notification from CVS Caremark sometime in 2018 that they could not disclose to any government agency any information about their contracts with CVS. And that's one reason we put the gag clause in, is that obviously they can't disclose proprietary information to me or individuals, but in our case, the insurance commissioner may need to know what the contract actually says so that he can help provide full coverage in the state. So we did put a gag clause in there that under the correct arena, the individual pharmacy could disclose to the insurance commissioner or others deemed necessary the wording of the contract.
I see. So
something there, Alan?
Absolutely. I was just going to follow up and say that often what people are referring to when they talk about gag clauses in this context is a prohibition on telling a patient that they could get a drug at lower out-of-pocket cost by paying cash than by going through their
That's correct. That was
benefit.
another thing is that often a patient can receive medication over the counter or by signing documentation for the medication and pay for it out of pocket at a lower cost than they could running it through the PBM, and the PBM establishing the copay. The copay would be much higher than what the actual cash value of the prescription would be.
Right.
And I just quickly want to add that that's part of the Nevada legislation, but that while this is a very popular thing that's happening now across the states, there isn't really conclusive data that says that this continues to be a practice that actually happens between PBMs and pharmacies. And I personally think in a lot of cases it's a red herring to distract from the overall problem, which is the high cost of drugs. And so it's, in my opinion, a kind of token action that we can take to make us feel better at the state level, but that doesn't actually get to the root of any problem.
Thank you. Well, I've been scanning the horizon for our next speaker, and I've been handed a note that says he's on his way here from the White House. And so we will take a a short break. We'll take 10 minutes and resume with a speaker from HHS. But before we do that, if you would join me in thanking our panelists for a great discussion. Really good job. So thank you all, and we will reconvene at just a few minutes past 2. So I'm very pleased now to be able to introduce John O'Brien. John is advisor to the Secretary and Deputy Assistant Secretary for Health Policy, working on the President's blueprint on drug pricing. I won't recap his whole CV inside or outside of government at this stage, but I assure you he brings a deep background in pharmaceutical policy, and delighted to have you here.
Well, thank you, Alan, and thanks everyone for being here. I'll note that I'm usually the other John O'Brien. For those of you that follow health policy, you know that there's many of us in town. I am not joined by my good friend and colleague Dan Best, who is the Secretary's Senior Advisor for Drug Pricing Reform. We were just at the White House and things are running long, and we split up so that I could be with you. Today is going to be even more interesting than yesterday was. So sorry to be a few minutes late, but really grateful for the invitation. So thanks again. I think it's important to just sort of ground folks in where we went with the blueprint, right? So I think there's sort of three important ways to think about how that was organized, and then just sort of step through that really quickly, and then we could see what questions folks have and do our best to answer them. I will say right up front that we have had a number of very good meetings with outside stakeholders. It's great to see one of them, and many of them here, but one of the greater conversations. It's been enjoyable to just be very candid with each other. I think the beauty of having an RFI out there has been the ability to say to people in settings like this, please don't wait until day 59 of the comment period to send us a 44-page comment letter. We would really rather have you come in and talk to us about what you think we should do. And that's led to physician organizations and insurers and manufacturers sort of coming in together and saying, like, we typically don't agree on this stuff, but here's where we think we should go. So it's been a very interesting comment period. I think Monday is the 16th, and I think that's when it closes. I don't know that I'm going to open that docket until the All-Star game's over on Wednesday, but that's neither here nor there. So if you want to come to the Home Run Derby and discuss your comments, we'll still take them. But the blueprint was by and large organized to address what the Secretary believes are four important solutions to the drivers of the drug pricing problem. One is to increase competition. The other is to improve negotiation. The third is to address incentives to lower list prices. And the fourth is lowering out-of-pocket costs. And then from there, we divided it into these are the things that we've done. These are the things that we are going to do, sort of in response to the President's call to action. And then the third was really, these are the things that we're actively considering, and you could almost interpret that as like, and really want to do, or think that we should do. But we recognize they have the potential to be disruptive, or that there are some open questions and strong opinions across different stakeholders. So it would be great to get people's feedback on them. Now, by feedback, we've really tried to tell people, particularly manufacturers, please don't come in with the 2005 talking points. Like, we've heard them, we know them. We really need to get past that. Because to be candid, the Secretary is pro-patient, pro-innovation, pro-competition, and quite frankly, really standing in between the industry and some faster ways to lower prices that some would say are not pro-competition and pro-innovation. So we have heard from a number of folks and explained exactly what we've explained to you here, and have also described that there were 4 areas that we thought we might be able to achieve traction quickly. One is on moving drugs from B to D, or bringing Part D tools into Part B. The second was for those companies that choose to advertise via DTC, requiring their list prices to be in their DTC ads. The third was, I'll say rebates, sort of the general topic of rebates, which many people have interpreted as addressing the regulatory discount safe harbor to the anti-kickback statute as it relates to rebates on prescription drug products. And the fourth was unleashing Part D. All of these have the potential to get very wonky very fast. I would say to just sort of go to like plank 2, improve negotiation. We had the event in the Rose Garden. For those of you that don't know, there's 2 versions of the blueprint. There's like the glossy cover one at hhs.gov/drug pricing, which doesn't tell you where to send your comments, but looks pretty. All of the questions are still in there, but the sort of official version is the one that posted to the Federal Register and has an open docket on regulations.gov. I will note the thousands of duplicate comments we've received from pharmacists on DIR. To all the community pharmacists in the room, we've heard you. 1,200 times we've heard you. But on the plank of improving negotiation, we really wanted to focus on where there is no negotiation in Part B and where there was negotiation and there is negotiation, but maybe negotiation isn't happening as good as it once was in Part D. Because specifically, we believe when after the Rose Garden, people said, hey, the president said on the campaign trail that he was going to negotiate drug prices. He's not negotiating drug prices. It's no, we are absolutely negotiating drug prices, but we want to do it in the smart, sophisticated, targeted, pro-patient, pro-innovation, pro-competition kind of way. And I think B2D is kind of one of those classic examples there where if you look, and I'll just say, I think the secretary used rheumatoid arthritis on the Hugh Hewitt show as an example. He said, if you look across B and D, you see a number of different drugs that on the commercial side may be competing with each other. But in this benefit, in the Medicare program, they are not competing against each other. And on the Part B side, they're not competing against each other at all. And the discount that one would get in a commercial plan isn't being realized in the Medicare program. So what would happen if we could get that same level of commercial discount? Now, I think as we were walking out of the Rose Garden, Avalier published their here's the problem with going from B to D analysis. And, I think the devil's in the details of Matt's sort of second sentence of Matt's quote in the press release where he says, obviously this is going to be different depending on like what class of drugs that you're talking about. But as a general rule, people in Part D are likely to be exposed to more cost sharing. 27% of people don't have Part D. And oh, by the way, there are some people who aren't a good choice to use a drug that's in Part D. To which, if this was like a happy hour, we could all look at like Part B spending and Part D spending and say, what if I could save so much money over here on Part B, on unrealized discounts, that I would have the money that I would need to overcome these people have supplemental coverage that's wrapped around, or these people aren't a good choice to use a self-injected product, so maybe they shouldn't be going over here. The B to D example is not meant to be a blunt, uninformed conversation. It's meant to be we have a type of negotiation in Part D happening that isn't happening in Part B. What can we do to bring those two things together such that we can achieve savings and do so in such a way that doesn't interrupt continuity of care and harm patient access? Unleashing Part D, I think, is another important part of the improving negotiation conversation, specifically, again, sort of in varying degrees of wonkiness. If you're a Part D plan and you have a CMS-approved formulary, you may still be reluctant to manage to that formulary because every time you do the utilization management that CMS has said when reviewing your utilization management criteria before the benefit year starts, if you manage to that, there's a risk that a patient will go through the appeals and exception process and maybe even appeal to an independent review entity. If you lose some of those independent review entity cases, you actually pay a penalty in your star rating. So some plans have just sort of reached a level of frustration from what we're hearing where it's like, yeah, we know this is in our formulary. We know that we could probably do appropriate utilization management here, but we just don't want to mess with it anymore because it's costing us too much on the star rating side. If you sort of move up the ladder there, there's some thinking around, or there's some questions around indication-based, and I think the term indication-based means many things to many people. But on the Part D side specifically, the Part D plan basically has to cover a drug for every medically acceptable indication for which it's approved. And that makes it very difficult to do utilization management where a drug maybe isn't the best choice for a therapeutic area. So there's some question about, well, hey, if we, the Part D plan, think that this is a really great drug for this condition, but think that this is a better choice for that condition and would rather prefer this for that and this for that, can we do so without having them on the same copay tier, the same cost-sharing tier? So those are some more questions that have been asked. And on the protected class conversation, I think it's really important to note, particularly in this room, because I see people who not only know their Part D policy, but also care very much about patients and access, and state first and foremost that we do too. We know what happened in, was it 2012 or the 2013 call letter where they tried to do something different on the protected classes. But it's important to note that the same manufacturers that are talking about how important it is for these patients to have access to these drugs are offering a very different level of rebate or discounting in the Part D program than they are in commercial programs. And of course, I can't disclose what any of those individual level rebates are, but there's a lot of money that is being offered in terms of discounts to commercial plans who are covering those drugs that is not available on the Part D side. So there's a question, how do we, in a pro-patient, pro-competition way, try to get lower prices for these drugs that we all agree are so important to manage patients with these 6 very serious, not to be messed with chronic conditions? How do we all agree that these conditions are so important that access isn't the only thing that's important, affordability is too? And then the last piece of that to touch on really is the rebate issue. If you watched the Secretary's Senate Finance hearing, you sort of heard the conversation about, and we'll just describe sort of a hypothetical scenario for the purpose of this room, how difficult it could be for a manufacturer who comes in and says, you know what, you're right. My gross price is here, my WAC price is really here, and for all the reasons you've described, I've been using these rebate dollars to either maintain preferred access on a formulary or deal with discounts that I have to offer to another side of the system. Let's lower our price. Let's lower our WAC price down to our list price. You could imagine a benefits manager who may have a contract with that manufacturer for a certain level of rebate, be it a percentage or dollar amount, who also has downstream contracts with insurers saying, I will get you this level of discount as well, asking itself, well, if we've guaranteed this to them and they're going to make this change such that we're no longer going to get that revenue, like, what does that mean? Now, I think we've received letters on that topic. I think the Senate has sent some people letters on that topic, and I think we're all sort of very interested in hearing what is a very individual, company-specific situation. And when I hear from insurers individually, I hear we would absolutely want the lowest ingredient cost, whatever it takes to get to the lowest net price. We don't want a situation where there is a better therapeutically, a drug that performs better clinically that we're not using because somebody else is paying us a higher rebate. We don't want to hear that there is a drug that launched at a lower list price that we're not using because we're getting a higher rebate for the old drug with the higher list price that has chosen to compete not by lowering its price, but by saying whatever price they're going to give you, we will rebate down to that. So those are obviously very individual situations for each individual manufacturer, PBM, and insurer. But there is a belief that this gross to net inflation is what's causing some of the pain that exists in the system, particularly because, and I'll look to NHIS here for an answer, I think 47% of people with a private insurance benefit today now have a high deductible health plan. And 1 in 7 have a separate drug deductible. So if I go to the pharmacy and I have a $1,500 deductible, I'm going to be told, by and large, what the list price, or maybe just a little bit off of list that the pharmacy may have negotiated, price is. That's what I'm going to pay my copay on. If I'm in Part D, that's what my cost sharing is based off of. It is not based on the post-adjudication down the road rebated amount. So if there's a way to lower that bubble so that the people who are paying out of their own pocket can have access to those lower costs, that's something that we're interested in hearing about. So I think from there, I'll say that there were 163 questions or 163 question marks and only 162 questions. I don't know how on 70 rounds of clearance a second question mark made it out in a sentence, but it did. But we closed with 3 other important questions, which is, what didn't we ask that you think we should know? What should we do? And what data do you think we should see to be able to learn more about what we should do there? So if anybody has good ideas or strong reactions to any of the things that we've asked, we're very interested in them. We want to hear about them, and we'd be happy to meet with you without necessarily going through the comment process, though we hope to ultimately make all of those comments public for those of you that do choose to submit them. So with that, I'll just again thank you for having me and everyone for being here, and see if we have time to take some questions.
Well, great, thank you. I know there are at least 163 questions in the room, and I have that many myself, but let me start with 2 quick ones, one that you spent some time on, one that you didn't, and then we'll open it up to the floor. So you talked a lot, and I hear this, on the one hand, the concern and the unease about the growing gross to net spread and the rebate system, and on the other hand, about how do we bring in these commercial tools into Part B which is basically somebody cobbles together some market power and negotiates rebates. Can you reconcile those two apparently seemingly contradictory trains of thought?
Yeah, I think you don't have to use market power to get rebates. You can use market power to obtain discounts, to actually lower the price of the drug on the front end so that competition looks like this, where prices are coming down, not where prices are going up and then the rebates are coming in on the back end. Because to the consumer, not only are you paying your co-payment or your co-insurance off of the list price, right? In Part B, like that's what your 20% is based on. Not only do you not get the benefit of that if it's lower, your plan is based on all of that additional spending. Now, it is true from a health plan perspective that those rebates flow to the plan in the form of revenue. Where they apply that revenue in a medical benefit is sort of up to them. And I saw Leanne from AHIP here. You know, I guess 3 years ago, we were at an NAIC meeting, and every year there's sort of that annual Avalier study that says prescription drug prices aren't the reason why your insurance premiums are going up. It's outpatient spending. Well, guess what's in outpatient spending? Medical benefit drugs. So the ability to lower the spending on those medical benefit drugs or Part B drugs is a way to not only lower what the country is spending, but to lower consumer out-of-pocket costs as well.
We could spend a lot of time on that, but are you envisioning that someone will pay list price, or will there always be a negotiation from list price, whatever we call it, discount, rebate, whatever?
I think there'll always be some form of negotiation off of list price, but I think if the list price is closer to what the discounted price actually is, if there was a way to sort of reset that in the system so that the consumer was actually paying the discounted price at the pharmacy, and then figure out perhaps through a small chargeback what is necessary to make people between the manufacturer and the pharmacy whole, as opposed to having money flow in the form of rebates to a PBM that gets passed around through the system is another approach.
Fair enough. Let me ask you about something that you didn't mention, which is Medicaid. So everyone in the room probably knows that Massachusetts applied for a waiver that would have let them exclude some drugs from their Medicaid program. That was turned down, but they were pointed to an opportunity that the administration has announced, which is states can opt completely out of the Medicaid rebate discount program and manage their Medicaid program like a commercial plan, have a formulary, and so on. Are you in conversations with any states? What can you tell us about why a state might choose that?
Well, so first, our budget included a similar proposal, right, calling for a 5-state pilot to do just that. I think we've been involved in a number of conversations with states or folks that represent states or folks that are interested in what states can and can't do about the different approaches here. We are very interested in what states think would be is a good path forward there, without being able to speak specifically to the decision-making process in Massachusetts.
Questions? There might be a few. Back here.
Hi, hello. Peter Maberduke from Public Citizen. I was curious, you'd mentioned that the Secretary is standing between industry and faster ways to lower prices. So what would you say to those of us for whom that's precisely the concern, that we should be looking at more robust mechanisms, that we have a problem of monopoly power where prices aren't actually related to innovation?
So I think we're looking at a number of studies, and I think it wasn't just CBO. I think it was a Peter Orszag quote that said, you can't save money by negotiating directly unless you have a single restrictive formulary. I don't know that a single restrictive formulary is where people think is the best thing to do in Medicare. Certainly, you could say, like, we're only going to cover one drug in each of these classes. Who wants to be it? Tell us what your discount's going to be, and then we're going to close the class. I don't think that's what the Medicare program was intended to be.
Sorry, but so if there were an alternative incentive or point of leverage for negotiation apart from the formulary, that might be something which the administration is open?
What would that be?
Say a value-based price from ICER.
So I think we've asked a number of questions about what we should be thinking about in terms of value-based. Now, are you saying that there should be a value-based price from ICER and that will be the reference price and the government will never pay more than that, or the government will cover anything that comes in under that? I think for me to give a short answer in a venue like this does disservice to the details of the question that you've asked. I think as I look at ICER and some of the different value frameworks, and even some of the things privately that people have created the value frameworks feel about them, I think there is some utility there, but it's not necessarily like this is the answer. So I encourage and welcome your thoughts about how we should be thinking about that. Yeah, well, I feel like we're in a free-for-all now anyway, so.
This is your question. So, I mean, a lot of people do enter this debate and they say exactly what you say. The only way you do it is you can take something off a formulary. And I get that, and I understand that that's where the debate starts. A different way you could think about it is to say when a new drug, so this is not everything, but something that enters, is highly expensive, has no competition or no alternative, you say the government begins to consider a reference price. Throughout ICER is just a point that is out there. But you could also, I mean, the blueprint has talked about foreign prices. You could potentially consider foreign prices as reference prices. So it's not negotiation, so it may not be what you're saying. It's more of a reference price approach, and it's approaching a drug where there isn't competition, because that does occur, and D was constructed around the notion that there would be competition, but there isn't always, and that's always been a struggle for D on how to deal with that particular situation. Now, he may need to disassociate himself, because I jumped in the middle of that, but it's right here if you want to.
Well, and you raise a really important point, which is this conversation isn't just about drugs, right? When I look at just Part D, for example, there are a number of drugs in very competitive classes that are paying very large rebates, and those rebates are likely being used to buy down the cost of some higher costs, lower utilization products that don't have any competition. Whether or not there are things that can be done to lower the costs of those drugs, in the absence of rebates, in the presence of other information, by adjusting other things is exactly the kind of question, the types of questions that we're asking. I will tell you the other thing I didn't mention is yesterday's tweet. Yesterday was a very interesting day. Without getting into too much detail, I think we went into this from a very pro-competition, pro-innovation. There are some places that we're never going to go approach. And the last couple weeks and those price increases have made it harder to do that. So I think, again, to the people that have other more interesting ideas that aren't, let's just have one drug per class and close the formulary and restrict access and chill innovation. We're very interested to those ideas, perhaps more so than we might have been in the past.
We have time for one or two more. One question up here.
Jibai from Johns Hopkins. So if we get rid of rebates, everything come back to discount. So I was wondering, how can we incentivize PBMs to generate savings? So probably you have to link their performance with some kind of the discount, right? And then that will again create an incentive for pharma to increase the list price. So I was wondering, what do you think about that?
So there are PBMs and pharmacies that work together to buy drugs at a lower ingredient cost level. It is possible for me as a health plan to say, I'm going to pay you X much per year to get me the lowest possible ingredient cost. So I can have the lowest pharmacy PMPM, because the lower my pharmacy PMPM, the lower my premium is actually going to be. Some have said that the reason health plans don't want to do that is because if I'm paying a PBM a fee to negotiate on my behalf, that's going to count against my MLR. But if it's a rebate, the way that the accounting laws allow me to book that is different. I mean, this conversation spins out really quickly, but there are PBMs and there are health plans and there are pharmacies that work on a discounted ingredient cost model on the front end without using rebates on the back end.
We have a question back here, and I'm going to make that the last one.
Hi, Leah Salzano with Public Citizen. As you just said, the recent tweet from President Trump and the recent raisings of pharmaceutical drug prices by Pfizer and other companies has led to some concern. And you said you were looking for suggestions, and I'm wondering things such as a price gouging enforcer and ideas that drug makers need to provide justification for raising prices were some ideas that were introduced by Democrats. So I'm wondering why that hasn't been taken into consideration.
Well, I don't know that it hasn't been taken into consideration, right? I mean, we are looking at prices and looking for price increases every day. We know about them before they show up in Politico, believe it or not, and we do contact the companies and find out, what's going on. What we haven't done and haven't proposed to do, and if you have thoughts about why we should, please feel free to suggest it, is asking companies like why they felt the need to take a price increase or why their price really is what it is. I think what people really want is a lower cost drug. And many state transparency bills or rate review-ish bills may just be looking to get the information that is necessary to say, see, you don't really spend this much on that. Now we can shame you into lowering your price. I would just as soon get to the lower price. I do believe that drug companies make significant investments in research and development. I do believe that there are failed products that money is spent on that never make it to development. I do think that we spend a lot of money on direct-to-consumer advertising. I do think that everything all flows together. I just don't necessarily know that telling me as a percentage why that happens helps me do anything about drug prices unless I'm willing to actually set drug prices. And we are not willing to set drug prices because, again, we believe that price controls or access restrictions is a way to get to price controls, ultimately doesn't save money, harms patients, and leads to a decrease in innovation.
So, last question, John. I thought if I asked you about yesterday's tweet, you would just point me back to the blueprint. but you seem to hold out here the possibility that that tweet points to policies that we haven't yet seen from this administration. Really realistically, how likely is it that we will see substantial additional policies that haven't been signaled in the blueprint out of this administration, or is this kind of it? This is the menu.
If you could see the thought bubble above my head during your question, it would say, like, I want to say change is coming, right? And then I think about the article that I read and like, well, the secretary said this here, but like somebody else said it there, right? And it's like, I can't show you, like, where is it, my back pocket? I can't show you the calendar, right, that says, like, these are the things that are coming, or these are the things that may be coming, or these are the things that we want feedback on. But I would say that what the secretary said in his tweet, what the secretary said at the 340B conference, are all indicative of a desire to do more, and more may or may not, well, may extend, quite frankly, beyond what was included in the blueprint. It certainly hasn't made things any easier.
Thank you for being here.
Thank you.
Up and come up here, and I am going to hand this over to our moderator for the second session, who's Erin Mershon. Erin covers the politics and policy of healthcare for the publication STAT, and that has included extensive coverage of drug pricing policy, so we're glad to have Erin here to moderate this next session. Erin's based in Washington, but as she announced yesterday on Twitter, it was a big day for drug pricing news on Twitter yesterday, she is shortly going to move up to STAT headquarters in Boston, at least for the next year, to take on the responsibilities of a news editor. So congratulations, and thanks for doing this.
I'm really excited to be here to talk about such an exciting topic and to follow such exciting panels on state efforts to address prescription drug pricing. And then obviously, I think John from HHS gave us a lot to think about in his last presentation. So I'll invite the rest of the speakers up to the stage. I think Mark is still getting mic'd up, but we have today Jane Horvath, who's an expert in state prescription drug policy and who most recently worked at the National Association of State Healthcare Policy. Did I get that right, Jane? Yes, perfect. Okay, and we have Mark Miller, who is the Vice President of Healthcare at the Laura and John Arnold Foundation. We have Hamie Tawerson, the Director for the Center of Best Practices Health Division at the National Governors Association. And we have Sean Dixon, an Officer of Drug Spending Research Initiative here at the Pew Charitable Trusts. And before I dive into the many questions I have for this panel of experts, I'm going to give each of them a quick chance to sort of explain who they are, where they come from, and why they're here to talk about state prescription drug pricing initiatives today. You want to kick us off, Jane?
Sure. So I'm Jane Horvath, and I have been working with the National Academy for State Health Policy and working on basically state policies to contain the costs of prescription drugs. And we have an advisory body of 18 state officials running from the governor's offices to prisons to public health to Medicaid that advise us on our work. We've put out model legislation in a bunch of different set of different approaches to how to think about containing drug costs. And why states are interested, the last panel talked about that somewhat, but with the states that I've worked with, if you actually sort of do some quick math, between state employees, independents, state retirees, local employees, prisons, university systems, and Medicaid, it runs the gamut. So states have a stake in the pharmacy benefit of anywhere from 25 to 31% of the population, just in the states that I have worked with. And that's substantial, plus any tax expenditures that a state spends for reducing anybody's income tax obligation due to healthcare premiums as they go up. So it is very, very substantial.
All right, excellent. Mark?
Okay, I think I'm at the wrong conference because most of my experience has been at the federal level. So OMB, CBO, CMS, and then the last 15 years at MedPAC. And I moved over to the Arnold Foundation about 6 months ago, and in our phone call Aaron suggested that I tell you who they are, and that's probably more relevant. So it's a relatively new foundation in the sense of 8 to 10 years. The Arnolds have decided to spend out the money that they've accumulated during their lifetime, and they're very involved in the decision-making process. They've gotten into education, criminal justice, public finance, research integrity, and also healthcare and drug prices in particular. They're very motivated by cost containment concerns, as I mentioned, about drug prices, but also things like provider consolidation and commercial prices, avoiding unnecessary services, and caring for complex populations at a very high bumper sticker level. They also have efforts in the opioid space and in the criminal justice space, and some of the conversations so far have touched on areas they care about. We fund a lot of activity in the state arena, which I would characterize as formulating policy and providing technology or technical assistance to various states. We fund the National Academy of State Health Policy. We have also funded the National Governors Association, the Maryland State Health Initiative, which I'm sure I've gotten wrong, and a number of other kind of state either organizations that are providing information and policy or just providing general technical assistance to the states. And so that's how we're involved. And I'll stop there.
All right, thank you. Well, thanks for having me. I'm Hamie Tawarson. I work at the National Governors Association. I'm the director of the Health Division. And one of the things I just wanted to tell you about the National Governors Association, if you're not familiar with us, we are a bipartisan organization. So unlike the DJ and RGA, we are truly bipartisan. Our chair is Governor Sandoval from Nevada, and our vice chair is Governor Bullock from Montana, Republican and Democrat. And one of the things that we do where I sit in the Center for Best Practices are we really are a think tank consultancy group for governors and their senior leaders, really working on what are the policy priority areas, how can we help them move forward on, healthcare, which is always difficult, fraught with politics, challenges, funding questions. And so what I do every day is thinking about what are the priorities that they need to work on and how do we help them move forward. The reason I'm here today is we have invested a fair amount of time on this topic of pharmaceuticals. And one of the reasons I wanted to highlight for you all in the audience is because it is a continuing question from states. And we are bipartisan, so there are different politics involved in this, but the question of how do we drive more value into our system, both on the Medicaid side as well as with state employees, retirees, and correction populations continues to come up as a priority area. So what we've done for the past number of months, since about November 2017, is create a project around how do we think about all of these pharmaceutical innovations that, in our project, it was focused on public health crises. So where are the public health crises? We heard a little bit about the diabetes in Nevada in the first panel. The public health crises that we talked about in our project was hepatitis C and opioids, and I could talk a little bit about that later in the panel. But really focusing on that piece of the pie, thinking through, okay, if you're a state and you have a cure now for hepatitis C, but you're still not getting it to the population because although the prices have come down, the number of people that have the disease continue to be high. And 3-point-something million people are infected with hep C, for example. So one of the things I wanted to talk about later today in this conversation is through that project, we worked with 11 states. We talked to a wide range of stakeholders, pharmaceutical manufacturers, health plans, consumers, providers, and really got input on what are the different strategies that the states are thinking about and what are your reactions to those. And I will later in this conversation, I'll talk a little bit about what those are. But one of the takeaways I just wanted to share with you all in part of this conversation is states have limited budgets. So unlike the federal government, they actually have to balance their budget every year or every 2 years. They cannot print money. And one of the biggest fears that I have heard from state leaders are, we know there's going to be innovations on the horizon. How do we prepare for that? How do we collectively provide access while also being able to have fiscal sustainability? So I think that's one of the things we're going to talk about today. Thanks.
Good afternoon. My name is Sean Dixon. I'm the officer with the Drug Spending Research Initiative here at Pew. I come to Pew after past stints representing pharmaceutical manufacturers and drug pricing, and then representing state governments and negotiating lower prices. So trying to bring that experience to our discussion today. What I'm really excited to talk about is 4 policy proposals that Pew has put forward. I think you have copies of those in your folders, and model legislation for each can be found on our website. These are 4 policy proposals that are really designed to help states immediately address rising drug spending. And they do it through one unifying theme. These 4 proposals have one unifying theme. That is to leverage the discounts available in the private sector into the public sector and into list prices. And I can talk more about how those policies achieve that in this discussion.
Perfect. So, and before we get into all the policy ideas that I know we have up here, I do want to take a second just to sort of set the stage. And you guys did a good job of starting us down this path in your opening remarks. But if you guys could talk for just a minute about sort of how big a problem this is for different states. Are they feeling it in a different ways in different parts of the country? Are there, sort of future concerns that are maybe more pressing than what we're currently seeing today? If somebody wants to just jump in and sort of paint the picture here of why this matters to states and state governments.
Well, I can start, but as I said earlier, it's like they have a huge stake in pharmacy benefits for state residents. It's huge, really. So that starts it, and that it's quite unpredictable in terms of budgeting purposes. Getting back to Hemi's point that all the state budgets have to be balanced, and the different components of them, the prison and the Medicaid and all of it. So it affects all aspects of state government and local government functioning and higher education functioning. And so it's a pressing need, and people don't see any relief on the horizon. And states are getting increasingly active about this. And we had the last panel talking about Pbm legislation in Arkansas. And this year, there were 84 bills introduced in different states having to do with different aspects of modifying the Pbm business model, a la Arkansas. And 25 of them passed. And that's a pretty high rate of passage. We had 12 states introducing a Maryland-style price gouging bill. Now, none of them have passed yet. There's some states still in session. But that's even in light of the fact that the bill has been, at this point, it's still working its way through the court system. But where the goalposts stand now is that it's been declared unconstitutional, but states are willing to proceed because it's so important, and they also have some faith that this will be declared constitutional at the end of the day. So to me, that's very significant. We have 3 states that have really moved forward in moving from transparency to actually trying to address the cost to consumers and to payers through a rate-setting legislation, and I know we'll talk about that later. And 9 states have introduced the NASHB Canadian importation model, which I think we're all still surprised about, and it's a lot of red states and a lot of blue states. NASHB works sort of on, of course, a nonpartisan basis, and we sort of feel like we have policy proposals that sort of address the political and geographic gamut of states. But the importation one has really crossed a lot of lines, political and geographic lines, and Vermont has actually passed it. So, and is working on implementing it now, getting a proposal to the federal government for approval. So it's a huge issue for the states.
Yeah.
And I think before rebates, I think Medicaid drug spend is something like $60 billion. I mean, that alone, and then try and quantify some of the other things that Jane had already mentioned, prison populations, state employees, universities, whatever. I mean, it is big, and I think, and I'll just, because I don't really know state area, but the same issue that affects commercial, Medicare, and the states is that, the pipeline is shifting to specialty drugs, and I think that is becoming much more unpredictable and scary to everybody involved, and the states would be part of that. And for whatever sets of reason, the things like the public health issues with Hep C, for example, does seem to be much more present in the states, and that they feel like that is coming at them much more directly. I may be wrong about that, but that's certainly what it feels like.
I don't think you're wrong about that.
Okay, thanks. I appreciate somebody finally saying nervous as hell up here.
So I would agree with all those comments. The one thing I would add is, when hepatitis C came out in 2013, it shocked everybody. There was no competition, and it was a cure. I mean, what a wonderful innovation. It cures a disease. There are going to be more of that, presumably, in the future. So, but at the same time, boy, was it a hit to the state budgets because they weren't prepared for it, and it was the numbers of people that had the disease. And in the Medicaid program, Medicaid specifically, they couldn't limit access in the way that they were trying to. There was litigation, there was sort of, letters from CMS. And so that created, oh my goodness, are we on this next trajectory? What happens when the next time this another drug, specialty drug comes out? So there's that piece. I think the other piece, Hep C is a good example of this. A lot of the folks in the prevalence of Hep C in Medicaid population and correction populations are a lot higher than in the commercial populations. We were talking to one state, and they were saying 40% of my corrections population has Hep C, and none of them are getting treated right now because I am in a budget crisis, and we cannot move those funds to that population. So even though that price has come down, given the prevalence of the disease in the population and the cost that still exists, for a cure, that's sort of the problem. And so I wanted to highlight that for you all. The other piece, I get this question asked a lot. Well, there's a lot of cost drivers in Medicaid programs and in state budgets in general. There's the aging population, there's hospital costs, and that is true. I mean, there are a lot of different pieces of the puzzle. I think what's caught the state attention was, number one, Hep C, frankly, in the Medicaid and correction space, but also the percentage increase in the past couple of years of that one category of spend. So it's not, on average, I think, of a Medicaid budget, pharmacy spend is between 5 and 8, 9% on average. So it's not, 60% of the budget, but the differential in the percentage increase outpaces all of the other spend categories. So when you're doing budgeting and you're predicting those at a state level, that's what pops up. So I think those are the factors, at least from my perspective, of why it continues to be a hot topic.
Well, and to your point about it being 5 to 8% of Medicaid budgets, we heard about correctional facilities earlier today. Of the 11 states that are able to report what percentage drug spend is of their healthcare spending, aside from Texas, they were all 15 to 30%, whereas Texas was spending about 7%, if I have that correct.
Kudos to you. Yeah.
And what that really shows is that there is a disparity in our system between list prices and these negotiated prices that happen, right? Medicaid is able to access discounts through statutory discounts, through inflation-based discounts, and then through negotiated discounts. We know that in the commercial sector, publicly reported prices of HCV drugs are significantly lower than their list prices, but for most correctional facilities, they're buying all those drugs at list. And so that's why we want to talk about using that power of commercially negotiated discounts and bringing that to the public sector, and then bringing some of that towards list prices.
All right, well, before we get into the nitty-gritty, let me just ask one more question, and that's about the sort of obstacles that states are facing as they look to innovate in this space. So is it largely the federal government that stands in the way? Are there internal considerations that are sort of challenging? What do you guys see as sort of the biggest obstacle, if I can ask you to pinpoint just one or maybe two?
Well, I can start.
Yes,
but,
please do.
States face a set of very significant, I would term them federal barriers. Between the federal law and then a whole body of case law that has built up around these issues. Senator Kinsella talked about trade secrets laws. Every state has trade secret laws, but also, even if they can adjust those laws to get where they want to go, there's a 2016 new federal trade secrets law that a lot of states are not even quite aware of yet. And that's a huge issue between the information that you want to present to inform the public and things that are considered to be business confidential. And so that's something, I think states can work through that, but that is something that they're coming to learn some the hard way. So that's been on the horizon. And then there's the Dormant Commerce Clause. The Commerce Clause was mentioned in the last panel. And that is in every lawsuit that we've seen so far that the industry has leveled against the states. And the thinking is that the federal government has reserved for itself the ability to regulate interstate trade. And there's a whole body of case law, most of it's really quite old and outdated, that doesn't anticipate. The Dormant Commerce Clause, really, our thinking about it needs to be updated for an industry that is global in nature, where the argument is that when states make decisions about regulating costs in their state, they're causing upstream, interstate repercussions and making business hard for manufacturers. But the point is, in the business model today of the whole industry is that pills are produced in one geography, shipped to another, and negotiations around prices and costs happen across all sorts of geography with interstate and upstream effects. And that's the voluntary choice of the manufacturers. So to say that that's a Dormant Commerce Clause violation, there has to be some new thinking about that. But it's a huge problem for states. And then patent law. States have been very reticent to get into anything looking like a direct price control because there is one, at this point, seminal case from the early aughts of 2000 where Washington, D.C. actually did directly set a price control standard on brand manufacturers. And the courts found that patent law, federal patent law, that Congress had intended innovators to have unfettered access to profits from their innovation, and that nothing could sort of move that, that right of theirs, including public health, access, citizens' welfare. And so that's been standing. And I think we need to rethink about that, too. I think that court case may be ripe for some new litigation, although states don't enter into something that they know is going to cause litigation easily, obviously. But we have the federal 340B program, which Congress created, which is a direct price control on every drug in this country to certain entities. So that tells me that maybe Congress didn't have this notion that an innovator should have unfettered ability to price to the extent that it affects health and welfare. So that needs to get rethought. We have Medicaid that we're going to be talking about later, which is, creates a lot of challenges for states. And 340B has actually become a bit of an issue in states that are really looking to move and affect prices at the point of service for consumers. 340B entities get deep discounts and they make margins when they're able to get it, acquire a drug at deep discount and then charge payers market price. So anything that limits their ability and squeezes those margins gets to be a big threat in the 340B program, and we're finding it's popping up in different states now. So, I think I would say just watch this space between the court actions that are happening now in several states and the seeming interest in the administration and Congress to modify or address 340B issues. A lot is potentially going to change for states. It's a sort of a moving target.
Yeah.
So when you talk about some of these federal barriers, I think we also want to look at what is possible to be achieved and what's being achieved in the private sector, right? We've seen that the actual net spending on drugs after rebates and discounts has not grown as quickly as it has in previous years, that commercial plans have been able to manage this. Part D actually had premiums drop this year, which signals that there was a decrease in certain aspects of the per member calculation. And so the question is, why aren't states able to access that? And part of that is, I think, this is a really complicated space. There's a lot of really nuanced regulations. But if we can think creatively about how to leverage those discounts are possible. Those discounts are being given in the private sector. We know the size of those rebates that are being negotiated. So what tools does a state have? Well, it has its Medicaid program, and it has its preferred drug list. And so can that be used to extend discounts beyond just Medicaid? Could that be a negotiating tool to extend those discounts to the correctional population? And then what about the power to tax? States, have the ability to tax things within their state. They can tax soda, they can tax cigarettes. Where can we think about having a tax based on the price of drugs and how fast those prices have grown? So these are tools that haven't necessarily been used yet, but that with some creative thinking, states could overcome some of the proposed challenges.
If I could comment just on that, I think that's absolutely right. And we talk about, so in our work, we talked about, okay, there's what the federal government can do, which is, I think, and some of the challenges that Jane outlined, and what can states do on their own, and then where do they need some approval from the federal government? I view it as kind of three buckets. And so let's just, like, for the state bucket, because that's where I spend a lot of time, talking about other populations besides Medicaid and like corrections, for example. How do we get better pricing for corrections populations? The one challenge that we've identified is how low can you negotiate before you trigger best price?
Can I just have you explain what triggering
Oh,
best price means?
Sorry.
Just in case, yeah.
Sorry. So if there is a price that's set lower than what Medicaid pays in a state, for example, if a state were to be able to negotiate a price that's even lower for corrections populations, the manufacturer would be required to offer that price across the nation. So that is something that obviously manufacturers aren't going to negotiate below, because that triggers a whole different set of considerations. And so one of the things we've been thinking about is it possible to waive best price when you think about how to negotiate additional discounts for a population like a corrections population? Is that possible? I think it's unclear, because then you're waiving a piece of the Medicaid drug rebate statute, and CMS has in the past authorized limited waivers of the Medicaid drug rebate statute, but they didn't approve of the Massachusetts request to actually close a formulary. So I think it's unclear in our mind whether even waiving best price is an option. I think the other piece is 340B, and we heard from sort of Texas about their success in really thinking about 340B. Now, 340B program is exempt from the best price requirement. So that gives you some flexibility to not worry about that requirement in the Medicaid drug rebate statute. And that's something that we've been thinking about and talking with states about as a strategy of, if you can expand upon that, you can get lower prices for corrections. I will say, and this is just sort of in plain speak, I feel like this topic is like an onion. So when you start peeling away one layer, you hit another and you're crying. So it really, that's just been my experience working on this for a while now, and I think, maybe others feel the same. But I just had to have a moment of levity in this. One of the things I think that we continue to think about is, all right, so there's the bucket that states can do things on their own, but it's limited. There are certain strategies, and I think preferred drug list is another one that you talked about, which I think, yes, some states can really do better on their preferred drug list. Some states can do better in thinking about leveraging generics. But then there's sort of the bigger wholesale changes that really are going to probably require some approval from the federal government, or a change to some of the things that Jane has talked about, which is sort of at the congressional level. So in my mind, those are kind of the tiers of strategies and challenges.
This started off as the barriers, and I think one is, and a lot of this point have just been detailed, but you have the amount of money that's present in pharma and in the PBMs, and they can mount political opposition, they can mount legal opposition, and then to your point, Senator, they can also activate the patient population, and that's very frustrating. And I was happy for her to say, among other things, that the notion of trying to be aware of when money is traveling to the patient populations was a significant issue in her state. Keep in mind, there's a sunshine law at the federal level which requires reporting on the part of drug companies and device companies. It includes lots of things. It does not include the patient population, and that could be changed. I think there is federal, particularly in the Medicaid space, federal difficulties, barriers in moving forward. I think it's very disappointing that the decision was made in the Massachusetts case the way it was.
Can you walk through that, since it's come up a few times?
I probably can't, but as long as you put me on the spot, and I have 3 people right here who can help me out, right? So, the way, and I think we were talking about this just within the last, 72 hours. The way I interpreted it was a policy decision that said you have to walk away from your best price rebate if you want to go out and start to have a more restrictive formulary and negotiate. And I want to be really clear, I could be wrong that it was a policy decision, but I didn't see that they did not have the authority to grant that. And so, to me, and then they have the 5-state demonstration. I don't see a lot of states that are likely to take that up if the trade-off is they have to walk away from these very deep discounts that they're getting under best price and rebate in order to experiment. And I would have thought that a way to go would be to allow a couple states to do it and see what happens. So that was kind of disappointing. And then some other points, and again, I believe people have touched on these, but just to bring them out, there are other things that when states take action, and Jane, you should make sure that this is right, when somebody takes up a bill, for example, and says we want to engage in importation, in the end, they still need federal approval to do it. And so in the end, they can go through all the politics and all the difficulty and all of Jane's sleepless nights to help them write the legislation, and then say, by the way, it still depends on somebody at HHS saying, yeah, go ahead, you can do it. And so there's some other notes I have here, but I'll stop.
Well, let me comment on both the Massachusetts case and then how that feeds into our discussion about corrections and best price. So the way that the Medicaid drug rebate program works is that manufacturers have signed a master agreement with the federal government to offer Medicaid certain rebates that are calculated under this formula, either by best price at 23.1%. And part of that contractual agreement that the federal government has signed is that states that participate in the program and take those rebates will cover all those drugs. And so the challenge is that there's sort of a disconnect between what the federal government may have the statutory authority to do in the Medicaid program, but then what its contract it's signed with manufacturers is. And so you have this contract law issue that creeps into all of this. And that's why in order to be able to exclude drugs fully from the formula, you would need to move outside of those voluntary rebates that manufacturers provide under this agreement. Those voluntary rebates, though, that can be set by best price, there are plenty of exceptions to the best price requirement. Notably, rebates to PBMs are excluded from best price. Otherwise, all of these discounts that we hear about to PBMs would be setting prices for Medicaid nationwide. And the other issue is that, as Hammy mentioned, sales to 340B entities, even not under the 340B program, are also exempt from best price. And so this is an opportunity for states to use their negotiating power to bring additional discounts to correctional facilities. Instead of having to meet the formal 340B patient definition the way the very nuanced Texas program has, they can have a voluntary agreement with manufacturers to route those discounted sales through a 340B eligible institution, and then just have the patients seen there through telehealth without having to meet that strict 340B patient definition. So there are voluntary ways that the power of the Medicaid negotiating, the state can negotiate in a whole. It says we're going to negotiate on behalf of both Medicaid and corrections, and we have a compliant way for you to pass those discounts along. And it's really just a small add-on to the large Medicaid population you're already voluntarily providing these discounts to. So it's thinking about how states can use their existing covered lives under Medicaid to negotiate and extend those discounts to other populations through the exceptions that are available under the best price statute.
Can I ask a question?
Please.
So that's an interesting idea. And so the folks who would be accessing the drugs that are at the deep 340B discount are not 340B patient definition people?
Right. So manufacturers were very concerned a couple years back about a proposal that any sale to a 340B covered entity that was no longer found to be compliant would trigger best price. And so in the Medicaid drug rebate program final rule in 2015, I know we're getting really deep here, the CMS declared that any sales to a 340B covered entity are exempt from your price reporting calculations. So none of those sales go into that average, they don't go into AMP, they don't go into best price.
Regardless
of whether they are under the 340B program or not.
Okay.
Well, you were at, where I thought you were going, Jane, is like, if you were to extend it to the state prison population, you might argue that it meets at least the spirit of a 340B, that this is a needy population. I'm sure people would argue and manufacturers would disagree, but where I thought you were going is, well, what if you were, and I don't know if this is what you were thinking, that what if you were to extend it to your state employees, that type of thing, and then gets into like what the spirit of the program is all about.
Yeah, and yes.
Well, this isn't about the 340B program. This is about voluntary manufacturer discounts, the same way they negotiate with PBMs, but finding a way to shield it from best price, just like PBM rebates are shielded from best price.
I think one question that's going to continue to come up is what is Congress going to do with the 340B program?
Yeah.
I mean, from a state perspective, that's what we're hearing, and so do we double down and really spend a lot of time thinking through this, or do we wait and see what's going to come out of the Congress.
Right, and obviously we
and
heard
clarifications.
Right.
So,
secretaries are making quite a few comments on that yesterday. And
yes.
I think there's some hearings later this week that will touch on this.
So states are risk averse for the most part, and they like to know if we invest a lot of time because we have limited resources, we want to know this is going to be a sustainable strategy. So I think that's the challenge. So.
On the best price thing, just to say that the federal government tends to have exempted itself from best price for all its programs.
Yes.
Medicare B, the VA, the military, the Part
But they
D.
could exempt correction.
So in terms of thinking about extending that latitude to state government that the federal government has extended to itself, like just exempt prices to state government agencies from best price, Medicaid sister agencies. Sounds easy.
Yeah.
But it's potentially a lot less convoluted than trying to access 340B.
I agree, and we talked about that idea.
But a state can do this on its own now. It doesn't have to wait for a change to the federal statute.
Right.
So since we are deep in the nitty-gritty already, I'm going to keep us there for a second. I think there are a couple of policy proposals that we've all talked about ahead of the panel that are really interesting, and I want to make sure we take a minute to talk about them. One of the ones that I think is most fascinating, particularly because it has a good catchy name, is the Netflix model. So I'm going to make Hamey talk about that one, sort of explain what it is, and maybe sort of how likely you see it is to proceed going forward.
So we've been talking with a couple states in this project about, okay, how do you want to think about Hep C? If you have a limited budget, how do you get more access to your population if you can't spend more money? And one of the ideas that came up with, what they came up with manufacturers is called the Netflix model. And basically what that is the state would pay an upfront fee to the manufacturer, and then they would be able to set, okay, you can have for that, with that fee, a much higher volume of hepatitis C treatment. And then there's different variations of the model, but once you hit a certain volume, you may have additional discounts you can negotiate that would allow you to go to the next level of volume, and so on and so on. So I think it allows the state to think through, okay, if we really want to go all in and treat more people, let's think about what we can do with our more limited dollars as we negotiate with manufacturers. I think some manufacturers are interested in this because it is a negotiation. And then there's a lot of opportunity to think about, how do you set, the level of fee up front? How do you set the supplemental rebate that you're going to negotiate after certain volumes, and so on and so on. One thing I would say on the challenging side, really being able to set those numbers and really from a state perspective, because that's who I represent, understanding and having the resources to figure out how to negotiate with the manufacturers is something that, they really have to kind of focus on. But we think it's definitely an interesting model, and we are publishing a paper with some of these strategies, I think towards the end of the month, and that will be in there.
So what has been the manufacturer response? I'm sorry, you said they're interested in it.
Some of them, some of them are interested in at least, trying to work it out with the state and figuring out how this could work. They do have some, questions around, does it trigger the federal anti-kickback statute? Do we need to think about, depending on how much discount we provide? That could be a factor. They also recognize that you may need a waiver from the federal government because you're going to be making an upfront payment to the manufacturer, which is currently not allowed under the Medicaid drug rebate statute. That's just not how payments organized right now. So, that would be an additional flexibility you would need.
Okay, so more of those onion layers that you were talking about earlier.
Well, I heard about this idea from her, so just to be clear, and at the time I was also like, why would anyone do it? And at the time, what she said was that, think of 3 different Hep C manufacturers, and you go to one of them and say, you can get all the money in this state, but you have to do it this way. Right. That was, because otherwise, why would a manufacturer want it? Right.
Well, I think one of the challenges you pointed out is states' ability to do this negotiation, right? That it requires a lot of expertise. And yet we also know that PBMs are doing this routinely for their large insurer clients. So there's already people doing it. And one of the things that we've been thinking about is how can we take those commercial negotiations and apply them to the state? When you think about how Medicaid was originally structured, these averages that they used to calculate prices were based upon what wholesalers were negotiating. We've moved away from that model, but we do have precedent for states requiring manufacturers to give additional price reporting in order to be included on the Medicaid preferred drug list. So Texas, for many years, had a requirement that states had to report, that manufacturers had to report a variety of additional sales information that was used to set pharmacy reimbursement rates. And that was a condition of being on the preferred drug list. You could take that a step further and say, if you want to be on our preferred drug list, you're going to have to report all the discounts you negotiate with PBMs, and we're going to get the best of that. So it also sets up new negotiating positions for states. States might not have the commercial knowledge of sort of where everybody is with their negotiations. By having that reporting, guaranteeing that the state gets the best price of, all of those PBMs, it also gives them more ammunition to negotiate even further discounts.
I think that's fascinating, and I want to stick with sort of states' ability to negotiate, and it's actually one of the states I don't think we've talked about yet today, and that's sort of what recently happened in New York State.
Yes.
I think there's a very interesting effort underfoot there, although I'm not sure it went the way that New York State was hoping. Can I ask one of you to kind of tell the backstory of what happened with Vertex there? And or are you thinking of a different New York model?
No, that same. Okay, I can kick it off, and then I'll let others.
Yep, I know a couple people want to jump in.
So New York has, I think, a pretty interesting model that other states are interested in learning more about. Now, they are a well-resourced state. They have really decided to invest a lot in this initiative, so I preface that with that comment. But they had decided, okay, we're going to have capped Medicaid spending. So over all Medicaid spending, we're going to have a cap, and then we're going to have a specific cap for pharmaceutical spending. And they set that with a lot of thought and, formula and all of that. And they decided, so if a drug exceeded that cap, then it would be called out, and the state would then go back and negotiate with the manufacturer. That would be the first step of, can we get an additional supplemental rebate to get you under that cap? So this is, something that they've just implemented recently. I think they identified, when they looked at their cap, there was 30 drugs that exceeded that cap, and they were able to negotiate with 29 of them to go under the cap, which, pretty effective negotiations. And, it's, I think, manufacturers like the negotiation piece of it. The next phase, I think there's one drug where they did not get to resolution.
They walked away.
And now that's, I think, does New York go to the next step and send it to their Drug Utilization Review Board? And I don't know if any of you want to comment on that piece.
They did
send
it. So
yes, go ahead, Jane.
And they're using New York State. Actually, my understanding of how they identify the drugs is if they look like they're going to breach the cap, they look to see are there any specific drugs that are sort of driving that spend in particular, and then it's those drugs. It's not an individual drug cap. And so they did have a lot of success, and then it gets referred if there is no negotiation, if a company refuses, then it gets referred to their Drug Utilization Review Board, which every state has. It's a result of a 1990 Medicaid law. Everybody has to have a Medicaid DUR board, and New York's was slightly repurposed to sort of assess the value of the product and recommend back to the state Medicaid agency the supplemental that should be negotiated in order to bring that product's net price to Medicaid in line with the DUR board's assessed value of the product. And they did all that, and they've also contracted with ICER to use the ICER methodology in determining what a drug's value, estimated actual value is instead of its price. And they held this whole meeting and came up with a value which was significantly different than the market price of the drug. And Vertex has still not negotiated anything at the last I knew. And it's a particular situation because the Vertex drug actually is like a very significant increase in clinical efficacy for some patients. So I think they're just sort of sorting through where to from here on this, and they have another level to go, but the question is, are they going to go there with this drug?
And that was, we talked a little bit of this on the phone. Part of all of that was my understanding too, that they got down to this one drug and the manufacturer refuses to come to agreement. But that's what spun off the thought in my mind, which caused the exchange, which I blame on Peter, that young man over there, which was his fault. But in my thinking was this was also a way to think about federal negotiation, that instead of this notion where everybody enters the debate and says, oh, it's all about taking drugs off the formulary, identify those few drugs that are entering the market, high price, no competition, and try and come up with a reasonable reference price, whether it's a value-based reference price or some other price, that you might be able to find and use. And then say that Medicare, like it does all throughout its program, says, we're going to set the price here. This will be our payment. This will be what the beneficiary's co-payment is tied to. And then you have a different dynamic. Instead of the government saying, I won't cover this drug, the government says, I will cover this drug at this price. I believe I'm saving the beneficiary out-of-pocket costs, and the manufacturer has to make the decision to walk away, which, of course, they can. Yeah. But when you're walking away from 55 million people, it might be different than New York State.
Interesting, yeah. Yes. Well, I do want to open it up to questions in a minute, but I also know that Jane, I asked you to mostly list all the sort of barriers and obstacles, and I didn't give you a chance to talk about some of the ideas that you're excited about. So
the upside.
Yes,
the
exactly,
upside,
the upside.
yes.
So I want to ask, I'll let you pick because I know you have sort of a few to talk about, but which one are you most excited about if I made you pick one?
The importation stuff, but I think people sort of basically understand that. But then there's also the rate setting model that we're trying to figure out a better name for. But so the rate setting model was introduced in Maryland, and Vinny from the Maryland Initiative is here. And it actually moved quite a ways through the process in Maryland, and it's also been introduced in Minnesota and New Jersey, pretty much as the NASHB model stands. And the concept behind it is we tend to talk about value of products, but the fundamental issue is affordability. The drugs don't really work if people can't afford them. And there are, these really important products that come to market that are just priced so that payers can't afford it, Medicaid can't. They create real challenges for the healthcare system, and the patients suffer. And so the rate setting model is where a state would set up a drug cost review commission, and drugs that meet a certain sort of reporting threshold, sort of built on the transparency laws, would report if they're coming to market with a drug over, say, $30,000 or $50,000. And then the public and payers, everybody would have an opportunity to talk to the commission about whether this drug really presents a problem in terms of financing and access. And if the sort of consensus is that it really does present a challenge, then the commission would ask the manufacturers for more information that would be confidential, and do deliberations, and ultimately come up with a number that is going to be the cost. So the cost of the drug to the healthcare system. And basically it's an all-payer rate-setting mechanism for certain drugs in a state. And so that payers can't pay more than that price, pharmacies and hospitals can't charge more than that price. And when you get at that level, like an all-payer payment rate-setting system, the consumer actually sees it, at the point of service, because that price, that reimbursement amount is what the patient's copay is, built on. So you actually get it all the way down to the patient level. And also, it minimizes the need for all this back channel rebate functioning. And our vision is sort of that the commission would think about at what payment rate would everybody who needs this drug get it? When does it? At what payment rate does it become affordable and patients have access? And obviously manufacturers don't like this idea, but I would argue if manufacturers.
I'm going to write that down.
I think if they actually thought about it, they could wind up making the same or more money than they do now. Like it's estimated that everybody who needs, only 20% of people who need the Hep C treatment are getting it. So there's a whole 80% of sales that are never happening. It's, revenue, I would say, sitting on the table for manufacturers. So if 100% of the people got it at a lower price, who's to say that their net income, their net revenue from this product is going to be less? I just don't see it. And they would also, manufacturers would get the benefits in the public relations game of having a price that people can pay. Instead of now they have to argue that all their money is going through all these backroom rebates and everything else.
Do states have the expertise they would need to make those kinds of decisions? I mean, it feels like it might be a little different in Maryland given their global budgeting arrangement and sort of what they're already doing in that state.
It's completely different than global budgeting. And yes, I think, you could, an analogy, imperfect, but an analogy is that, all states have public service commissions that take monopoly products that are really important to the public welfare, and they figure out what consumers should pay for it. And it's telephone, it's cabs, it's electric, it's water, it's sewer, it's all of these kind of complicated things. And they just have most states have 5 or fewer people sitting on these commissions. Even really big states, it's 5 or fewer people, experts, people who understand this stuff, making these decisions on behalf of consumers.
Can I ask a question about that?
Sure.
So interesting idea. So glad you're excited about it. So Maryland is one of the few states that's still just to switch to the hospital rate setting, that still sets rates for hospitals. There were a number of other states that used to do that, and they don't do that anymore. And so, whenever we talk about sort of rate setting to states that are not Maryland, their eyes get really big and they're like, oh, we don't do that anymore.
But they do.
So tell me what you would tell them.
But they do it, every state does it for important public goods, that have a monopoly.
Healthcare has somehow moved out. Yeah.
Well, I'm saying it's not different.
Okay.
They need to think differently about it.
Yeah.
They need to think about it as really important to the public health and welfare, and they really need to think about it in terms of affordability, as opposed to value is a really complicated concept. And I would argue that value is what then health plans would decide, not the state. Health plans would decide how valuable is this drug, where should it go on our formulary, and all of that. But in terms of affordability, that is a state rule.
Interesting. I want to open it up to audience questions. Anyone have one that they want to ask our panelists?
They're so tired by now.
Sorry.
They're tired.
I can ask a million more questions, but I don't want to miss the opportunity if anyone has one.
Okay, good talk.
Okay. Well, I will jump in and I'll say, I think Jane's opened up a really interesting question, and I'll broaden it a little bit to ask you guys, sort of what should states be thinking about when they think about drug pricing? Obviously, there's the state spending, but there's also considerations about patient out-of-pocket costs. And there are considerations of value. And I guess I'd ask our other 3 panelists, I guess, one, what are you seeing states think about? Is it all about the bottom line budget? Does it have to be? And, should states be thinking more broadly about the entire state population's, out-of-pocket costs on a given prescription drug or something like that?
So I would just start off. So the states that we work with, they think about Medicaid first because that's always the biggest budget item. And so for those folks, out-of-pocket cost is not an issue because it's nominal co-pays for Medicaid populations. Prisons, which don't have co-pays. So it's interesting because when we're talking with the administration, it's a lot of focus on out-of-pocket costs. And when you do the state work, they worry about that too for people in the private health insurance exchange and people who are uninsured. And state employees that have certain types of plans. But the first 2 populations that we focus on, Medicaid and corrections, that's not an issue. So it's a little bit of a hybrid for states. And one thing I did just want to comment on is, I think the blueprint, and I was very glad that John O'Brien could join us and talk about his, perspective on that. One thing that we found reading that blueprint was, wow, they really don't talk about Medicaid and what we can do more on Medicaid. And instead it's like, Medicaid gets good prices. So we read that blueprint and we said we have a lot more work to do because for states, the Medicaid and correction populations are always at the top of the list.
Yeah, that's really interesting.
So I would say on cost sharing, it's important to recognize that cost sharing is a function of insurance benefit design, right? It's the insurer who establishes the price that you pay, whether you have a plan that's all co-pays, a plan that uses co-insurance, or a plan that uses high deductible. And so patient out-of-pocket is really an insurance regulation issue. What do we think are appropriate insurance benefit design safeguards that help patients access drugs? What the problem is that price ends up becoming what we use to discourage utilization rather than saying, no, you can't have that drug under the benefit. And that's where what your income is ends up being determinative rather than that. So we can think about allowing more rigorous benefit design in terms of utilization management with lower out-of-pocket cost sharing, rather than leaving it to the individual to determine whether or not to take that drug. Make it on a clinical decision rather than a cost decision. And one of the ways that states can help finance that is to tax drug price increases. So we've got two stories. We've got high drug prices in general, but we also have drugs that are growing at a faster rate than inflation. And within the Medicaid program, right, there's an inflation rebate that offsets that. But there isn't necessarily that for whatever is being experienced out of pocket by patients. And so what we've proposed is that states could levy a tax on the first sale of a drug within the state paid by the seller on whatever price increase has gone over the rate of inflation. And then that could be put into a pool that states could use for offsetting premiums, cost sharing, whatever is most appropriate. And there's sort of two ways that this can go. Either manufacturers continue to pay that tax and then it's used to offset costs, or they choose to lower their price increases to be in line with inflation, and then we don't have to worry quite as much about those increases. So there are tools that states have that can address some of our concerns about patient cost sharing, but they might not come in the ways of just adjusting list prices.
Now, this is just a little bit off point because I think Hemi's answer is correct, that the states first think about programs that don't have any cost sharing. But in the commercial market, you've had this game where the benefit design said, okay, here's your cost sharing, and we're going to try and just move you from one drug to another drug. And then the manufacturer said, okay, well, here's coupons or patient assistance programs to kind of break that incentive. Then the insurer said, okay, well, now we're going to do accumulators. We're going to keep track of these things so that then it doesn't break that incentives. And now the manufacturers are creating cards that are undetectable to the accumulators. And so if you're wondering where the investment in innovation is going, it's going over here. And so the only thing I would say is I think both at the federal level, but also there are state abilities to go in and deal with the coupon issue where either banning it, but also things like saying if you enter into a coupon arrangement with a patient, it lasts throughout the entire duration of the benefit. It doesn't stop once they've hit their copayment, that type of thing. And it's an area that not a lot of people are paying attention to, but I think, and I'm sitting here with some state people, so I feel very nervous about this, but I think Massachusetts and California. That's correct. Is that correct? Yep.
That's
great.
This
is great.
Right. All right, any other, do you have a question?
I'm Bruce Rector from Doctors for America. When you look at this Netflix model for hepatitis C, have you looked at the Australian government hepatitis C elimination plan, the price volume deal?
We did not in a lot of detail, but we talked to some folks from Australia about that. And I mean, they have, just in terms of the model beyond hepatitis C, I mean, they have a lot more negotiating power with manufacturers, right? I mean, them in New Zealand, I mean, they have a lot more controls. So I think it's interesting that you raise that. I don't know if what they're doing, all those different pieces are exactly replicable here in the United States because of some of the different requirements that we have, including the Medicaid drug rebate statute, and how that impacts other populations like corrections. But yes, no, we did take a look at it, so thank you for sharing. Everyone has access, I know, and they've pretty much eliminated it. They've pretty much eliminated it, yeah.
Do we have another question over here? I feel like, yes.
Hi, Jim Scott with Applied Policy. I was wondering, when the federal government legislates mandatory rebates like the 23.1% in Medicaid, does that just cause drug manufacturers, when they launch a new product, to make it cost 23.1% more than they otherwise would have cost so they can make the revenue that they expected?
So, I mean, actually the blueprint implies that in many places that Medicaid is the cause of high prices. I found it pretty interesting that there were all these proposals to raise costs in Medicaid with the presumption that launch prices and everything else will lower. I don't think that that's the case. I mean, because everybody's, there's millions of prices out there for any particular drug in the United States. Well, maybe thousands of prices, you know, to individual payers and stuff like that. Medicaid is not the problem. It's just,
I think the way to think about it, right, is that a manufacturer is going to set a price at the highest willingness to pay of the commercial market.
Yeah, exactly.
And if the commercial market were willing to pay 23.1% more, then as a profit maximizer, they should have set the price there to start with.
Companies do, you know, when they're figure out sort of on average what their rebate or discount is going to be on a bunch of sales. I mean, because they're trying to make revenue projections. So it comes in that way, but it's not Medicaid, and you know what I mean?
Let's go there first.
Thanks, Mike Miller again. If I can just respond quickly to that and expand on what Jane just said. Yes, it'd be 23.1% if the manufacturer expected the drug to only be used by Medicaid population. But if it was for some pediatric indication, but if it was an Alzheimer's drug, then they wouldn't care about the Medicaid rebate. They'd be more worried about how Part B or Part D or Part A was going to reimburse and discount and everything else, and factor that into their launch price calculations. Or if it was a commercial, it's going to be solely for middle-aged working people, then they'd have another thing. And generally it comes out to some combination of all the possible different rebate and discount programs and government programs, VA, 340B, commercial, and everything else. And that gets put into the mix to figure out how they put in their modeling, which is usually, pretty wrong. And they find that out after they launched it.
I think we have time for just one more question right here.
I just wanted to clarify that actually most state DOCs do charge copays on the pharmacy, and that's actually on top of visit copays. So for individuals who are working at like 25 cents an hour, it's proportional to what might be real money for the rest of us. And they do have exceptions, but in terms of usually seriously mentally ill, the high need mental illness drugs, but the copays are definitely an impediment.
That's really interesting. All right, well, that's fascinating, and also I guess the place to end. So let me say first thank you to all of you guys for joining us, and thank you to Pew for hosting us today.
Yes, thank you.
Thank you.
I'll just wrap up by thanking Aaron and all of our panelists who spoke today. Again, thanking the Pew staff who worked hard to put this event together, Alyssa, Ian, Amy, Sean, and Danita. Hemi referred to crying when you peel the onion. I think we've heard the onion here has a lot of layers today: Pbm regulation, market transparency, innovations and corrections, taxations, 340B to get voluntary discounts and corrections, rate-setting importation, Medicaid caps, and the Netflix model. And that wasn't everything that was mentioned today. States have shown an ability to move legislation in this space, and I think the appetite will continue. So thank you very much for being here and for tuning in, and we look forward to working with all of you going forward.